So today I'm going to talk about antiarrhythmic drugs. So in the antiarrhythmic drugs, we have these classes or classification according to the 𝗲𝗂𝗡𝗂𝗡 classification. Now here what we have to know is that we have 4 classes and the 5th one is the miscellaneous drugs. So we are going to do class wise, what are these drugs, what are their major actions and where they are used. So first we are going to start with the first class, which are your sodium channel blockers. They are further subclassified into class 1A, 1B, 1C. And why is that? Because of the action on the potassium channels. So first one, 1A, which has quinidine, procainamide in it. These are the drugs which are going to block the potassium channels as well. So they are potassium channel blockers also. Class 1B, lignocaine, phenytoin, mexiletine, they are going to cause opening of the potassium channel. So these are potassium channel. Then 1C, enconite, flecainide, propafenone and moxazine, they have no effect on potassium channels. Right? So where are they used? So the first group 1A, which is potassium channel blockers. So these are used in supraventricular tachycardia and ventricular tachycardia. But remember, the problem with first A group of drugs is because they are potassium channel blockers, so they have a tendency to cause arrhythmia, which is 𝗓𝗪𝗔𝗡𝗃. Then the second one, which is lignocaine, especially as a potassium channel opener and sodium channel blocker. This is used for VTs, only the ventricular tachycardia. That is the main use. Remember, lignocaine is especially preferred in digoxin-induced ventricular tachycardia. 1C, see 1C drugs, the important thing to know about them, these have a arrhythmogenic potential also in them. So they are arrhythmogenic also. Right? So they have potentiate one kind of, they are treating one kind of arrhythmias and they are having another kind of arrhythmias here. So here the important thing, where are they used? So this is used for treatment of SVT. This is for VT and in the Wolff-Parkinson-White syndrome, where there is an aberrant pathway. Apart from the normal pathway, there is another pathway also as such. So these drugs are contraindicated in case of myocardial infarction because these are arrhythmogenic. So contraindicated in case of myocardial infarction. Moving on to the second group, which are your beta blockers. So all the beta blockers except sotalol, they belong to this group. So we have propranolol, esmolol, right? We have metoprolol. These are the beta blockers. Esmolol is a shortest acting blocker. Shortest acting beta blocker. So how they work? Beta blockers are going to block the beta 1 receptors. So therefore they are going to decrease the conduction. Decrease the conduction via the AV node. Also they are going to block the, or they are going to, you can say, the beginning of the, the point, which is the SA node. So they block the SA node as such. So SA node they are going to block. Number 2, AV node they are going to block. So what are they going to do mainly are, again, where is it more essential is in cases of supraventricular tachycardia. Why? Because they are going to decrease the traveling of the impulses from the atria to the ventricle, because you know the ventricle tachycardia fibrillation is the most dangerous. So they decrease the conduction of the impulses from the atria to the ventricle. So therefore they are used for rate control. We call them as, they are used for rate control. But then again they are contraindicated in case a patient has asthma. There we cannot use them. So one, they are used in this. Number two, they are used in other types of arrhythmia which is because of the catecholamine excess. So for example, in case of pheochromocytoma, thyrotoxicosis, right? So all these predispose to increase in the catecholamine level, and therefore that potentiates the arrhythmia. So arrhythmias because of this, we use beta blockers. You know, there's the drug of choice for thyrotoxicosis and pheochromocytoma. We first use the alpha blocker followed by a beta blocker. Then the third group are your potassium channel blockers. So in the potassium channel blockers, we have ibutyllide, 𝗏𝗡𝗏𝗏𝗏, amiodarone. Then we have dronedarone, sotalol. And the newer drugs like 𝗲𝗏𝗏𝗏𝗏, we have azimilide and 𝗤𝗏𝗏𝗏𝗏. Remember here, one of the most important drug is amiodarone. Now amiodarone, dronedarone, everything is same. Just the difference is amiodarone contains iodine while dronedarone does not contain iodine. That's why the adverse effect of the action on the thyroid levels, you know, that is not seen with dronedarone. Then sotalol, it is a beta blocker, but it has a higher tendency to block the potassium channels as well. So sotalol, it has class 2 and class 3 effects. Predominantly it's a class 3 effect. Amiodarone, apart from having the class 3 effect, it also has class 1, class 2 and class 4 effects, right? Now, important thing is, because it's a potassium, any potassium channel blocker, just as we did with class 1A drugs, they have a tendency to cause a special type of arrhythmia which is dangerous. They can cause torsades de pointes. It was seen with class 1A as well. Alright, moving on to the important uses. Now, amiodarone is one of the most commonly used drugs, right? So, amiodarone, they can be used in all types of arrhythmias, especially the ventricular arrhythmias, except torsades de pointes, right? That is very important for this. So, in the ventricular arrhythmias and the others, but it should not be torsades de pointes. Then the drugs like ibutyllide, 𝗏𝗡𝗏𝗏𝗏𝗏, they are used to control the rhythm in atrial fibrillation. For the rate control, we need drugs which decrease the conduction of the impulses from the atria to the ventricle, but also the atria needs to get back into its rhythm also, normal rhythm. So to control that rhythm, we have drugs like ibutyllide and 𝗏𝗡𝗏𝗏𝗏. Then we have sotalol, that can be used in cases of polymorphic ventricular tachycardia. Next, the fourth group, we have the calcium channel blockers. So in the calcium channel blockers, we have 𝗲𝗏𝗏𝗏𝗏, and we have 𝗙𝗪𝗏𝗏𝗏. Again, what they're going to do, they are going to block the SA node and the AV node. Never give calcium channel blockers along with beta blockers. Similar action, so they are going to further depress both of these. So they are contraindicated with beta blockers. So where they are given? They are given for maintenance, as a maintenance therapy in PSVT. So once the PSVT has been controlled, to prevent further attack, we give CCBs. Oral CCBs can be given in maintenance therapy of PSVT if beta blockers are contraindicated. Especially the condition is asthma. If the patient also has asthma, then we cannot give beta blockers. So instead of giving beta blockers, we give calcium channel blockers. Now, interestingly, there's a newer calcium channel blocker which is called as 𝗕𝗵𝗵𝗡. Important or interesting is that it is available as a nasal spray. So you can spray it when the patient develops paroxysmal supraventricular tachycardia. Otherwise, patient had to rush to the hospital and then you give IV adenosine. But here they can be given in PSVT acute treatment as well. In the miscellaneous group, we have digoxin, then we have adenosine, magnesium sulfate and atropine. Now let's see this. Now digoxin, what it does is, it is because it has a vagomimetic effect on the AV node, which means it causes conduction delay. Conduction delay, right, at the point of AV node. So where do you think it is used? It is used in case of atrial fibrillation in patients of CHF, right? Atrial fibrillation in patients of CHF. Then we have adenosine. Adenosine will activate A1 receptors which are present in the AV node. Now these receptors, actually these are GI kind of receptors which decrease the cyclic AMP, right, and they decrease the calcium influx, but they increase the potassium efflux as well. So they are depressing the system again. So this is a drug of choice in case of PSVT. Magnesium sulfate, they are just going to stabilize the myocardial membrane, right? So they stabilize the myocardial contractility. So they just work opposite to that of calcium. So therefore, magnesium sulfate is a drug of choice in case of Torsades de Pointes. Acute attack of Torsades de Pointes, magnesium sulfate is used. Atropine. Now, atropine is an antimuscarinic agent, right? Antimuscarinic drug which causes the M2 block. Therefore, it depresses the it will increase the heart activity, because M2 or parasympathomimetic, they depress the heart activities. So atropine is going to increase them. So where can it be used? It is used in case of bradycardia and it can be used in case of AV block. So these are the miscellaneous antiarrhythmics that is being used. Now let's do a question from the previous year. A patient with a history of myocardial infarction and ventricular arrhythmias has been on an antiarrhythmic therapy for several months. He now presents with fatigue, dyspnea, weight gain and pulmonary fibrosis. Which drug is most likely responsible for these effects? Amiodarone, atenolol, aspirin, spironolactone. So remember, there is fatigue, there is dyspnea, there is weight gain, there is pulmonary fibrosis. So out of them, we know that aspirin and spironolactone, we don't use them in case of arrhythmia. So that is ruled out. Now we are left with amiodarone and we are left with atenolol. So pulmonary fibrosis and weight gain and all these things, I don't see it with a beta blocker. But we know that pulmonary fibrosis is a hallmark of, it can be seen with long-term therapy with amiodarone. So amiodarone is the correct answer. Now, what are the important toxicity signs of amiodarone? So remember that there is 1T, 2P, 2L and 2C, right? So TPLC, 1, 2, 2, 2, everything rest is 2. So 1T stands for thyroid dysfunction. It can cause thyroid dysfunction. function. Then 2P stands for pigmentation. One is pigmentation, which is blue man syndrome. It is called as blue man syndrome, and the other is peripheral neuropathy. So here you can see this kind of a blue man syndrome that is seen with amiodarone. 2L, one is for liver and the other is for lung. So it is hepatotoxic. It causes liver toxicity and it causes lung fibrosis. Are we talking about pulmonary fibrosis? 2C, it causes corneal deposits, just like we see here, corneal deposits, and it can cause cardiac depression as well. Cardiac depression and corneal deposits. Now, apart from amiodarone, are there other drugs which can cause pulmonary fibrosis? Yes. And how to remember those drugs? We have a mnemonic called as BBC ban me. So let's see what are these drugs for us. So 1B is bleomycin. Then we have busulfan. C stands for cyclophosphamide. B stands for bromocriptine. A stands for amiodarone. N stands for nitrofurantoin, and M stands for methotrexate. So BBC ban me is a mnemonic for all the drugs that are important for you to know which are causing pulmonary fibrosis. Alright, so let's quickly glance through what are the important arrhythmias and what is the treatment that you should know about them. So bradycardia, AV block, I already told you, for these two we give atropine, which is an anti-muscarinic drug. Very, very important to know. PSVT, paroxysmal supraventricular tachycardia. So there is a sudden episode of supraventricular tachycardia which has occurred. So what is the drug of choice here? The drug of choice is adenosine. We give IV bolus. It's a very short acting drug, immediately produces effect, and onset is also, duration is also very, very short. So IV bolus. So in children, you use 0.1 milligrams per kg, and in adults, what do? You use 6 milligrams, that is the dose. Now, adenosine is contraindicated in case the patient has asthma because it is a bronchoconstrictor. So, therefore, we use CCBs. Parenterally, we use the calcium channel blockers for this, right? So, and also one thing more is that the blood pressure should be normal. Then supraventricular tachycardia, here if we talk about what is the difference in treatment. So we have to, you can give A, B, C, D regime. What else? Because the main point here is to inhibit the impulse traveling from the above the ventricular to the ventricle. So we have drugs which we give A, B, C, D in order of preference also. A is adenosine, B is beta blockers, C is calcium channel blocker, and D is digoxin, right? So remember, if there is asthma, then adenosine and beta blocker, they are both contraindicated. Then you will start with CCB as a choice in case of asthma, okay? Digoxin is usually effective in case of, if this is not working, then we go on digoxin. And why are we using? I've already told you that it has a vagomimetic effect on the AV node. Alright, moving to the atrial fibrillation. So in the acute phase, we can do cardioversion. For the chronic or maintenance, what do we do? The preferred drug of choice for us is beta blockers. But let's say the patient has asthma, then you cannot give this, then we give calcium channel block. That is very important to understand here. Now, if there is atrial fibrillation with CHF, atrial fibrillation with CHF, then we would prefer to give digoxin. Okay, so we prefer to give digoxin here. Now, ventricular tachycardia. So, what is important in case of ventricular tachycardia for us to know is the drug of choice here, or we prefer rather to give amiodarone. So, we prefer to give amiodarone here. But in case of ventricular tachycardia associated with digoxin, right, there the drug of choice is lignocaine. So, most effective drug here. Right? Ventricular fibrillation, here we have to do defibrillation. Okay. Now, what is the important thing to note here is that whenever in this atrial fibrillation, this is to control the rate, the drugs. For rhythm control, we need to give drugs like 𝗙𝗚𝗚𝗏. Right? We've done before that. So, for rhythm control, we can give you give 𝗙𝗚𝗚𝗏 or 𝗏𝗏𝗏𝗏. So, this was all to control the rate first, because that is the most important thing to do first, that we need to control the rate of impulses, which we don't want to reach the ventricle. Because ventricular fibrillation is the most lethal thing. It can cause death within seconds rather. Now, 𝗙𝗚𝗏 syndrome, what is the treatment? The best treatment would be you do the ablation of that, a particular region, ablation. But what is the other long-term treatment? We have flecainide. Right? Flecainide is a drug of choice here. Now, Torsades point is acquired congenital. Any case, if there is an acute attack, whether it is acute attack in case of acquired, whether acute attack in case of congenital, your drug should be magnesium sulfate. In congenital, later on, you can give beta blockers. Okay, so beta blockers are preferred in case of congenital, and which do we prefer? Propranolol. Now, in case of catacollar mean-induced arrhythmias like pheochromocytoma, ventricular premature beats, even in thyrotoxicosis, again we will prefer propranolol. Right? So, these are the various anti-arrhythmic drugs and the important points that you should be very, very well versed with. So, today we are going to talk about hypolipidemic drugs. So, first we should know the desirable levels of the various lipids. So, we have for the cholesterol, triglycerides, LDL, HDL. So, there is a simple trick to remember this, like for cholesterol, start from 200. So, the desirable level should be less than 200 milligrams per deciliter. Now, just keep on subtracting 50. So, for triglycerides, it should be less than 150. LDL should be less than 100. Now, in women, the HDL is a good cholesterol in all, we know that. So, it should be, the level is 50, remember, minus 50, but it should be greater sign. For men, it should be greater than 40. Right? So, these are the desirable levels. So, then only if in exam they give you these values, you can come to know whether it is on a higher side or not. So, moving on to now, the first question which was asked in the previous year. So, which of the following drugs act by inhibiting the PCSK9 and is used for lowering the LDL cholesterol levels? So, whether it is evolocumab, ezetimibe, bempedoic acid or clofipiride. So, the mechanism, the PCSK9 inhibitor here is evolocumab. So this makes us think, or you can understand from this, that it is important to know about the various mechanism of action of these hypolipidemic drugs, because we are asked often in the exams, out of one of these drugs will be asked. So let's now go and further do the important points about these drugs. What are the important mechanisms, the indications or side effects? So the first and most important, we have statins. So statins, also called as HMG-CoA reductase inhibitors, because they inhibit the enzyme HMG-CoA reductase, right? So with this, they will cause decrease in the level of LDL mainly. Indication, they are a drug of choice for hypercholesterolemia. Then they can be used for treatment or prophylaxis of in patients of myocardial infarction, in stroke, right? Especially if the patient has a high risk of, in the prophylaxis we can use if there is risk of atherosclerotic coronary vascular disease and the LDL is more than equal to 190. So for prophylaxis, definitely we should be using, or even in the treatment if we find the levels are high. So what to do here, because many a times this question is asked, if you're given that patient is at high risk of ASCVD and the LDL levels are 190, then what to give? You should definitely start a statin. Now which statin do we actually start here? So the statins which are called as high intensity statins, so we have two of them. One is rosuvastatin and atorvastatin. So remember, 20, 40, 80. Keep on doubling it. So this is the strength, 20 milligrams, 40 milligrams and 80 milligrams. So rosuvastatin, the dose is high intensity dose. Rosuva is 20 to 40 milligrams, and then 40 to 80 we have atorvastatin. Okay, so this is the dose of these statins. Side effects, important side effects to know here. The number one is that we should be worried about is myopathy. So they can lead to myopathy, which can lead to myoglobinuria. Number two, the other important is hyperglycemia. Hyperglycemia. So in a diabetic patient already, we'll have to be very careful there. Number three is hepatotoxicity. Hepatotoxicity. Now, these are contraindicated in pregnancy because these are teratogenic drugs. In children, in less than 10 years of age, we do not use them. So, contraindicated in pregnancy and in children less than 10 years of age. But we can use pravastatin. So, in children less than 8 years of age. Here, pravastatin. Okay. So, contraindication is pregnancy in children less than 10 years of age and in children less than 8 years of age. The pravastatin is another important thing to know. So, then going to talk about reasons. So, before I go on to reason, let's me discuss a little more about these statins because it's one of the most important groups here. So, we have lovastatin, atorvastatin, simvastatin, all statins here. Now, they are going to inhibit the HMG-CoA reductase we thought already discussed. So, this is the HMG-CoA reductase here, the enzyme which is going to convert the HMG-CoA into mevalonic acid ultimately for the cholesterol. So, this is important for the de novo synthesis of cholesterol in the liver. So, what happens when you block this enzyme? The de novo synthesis of cholesterol in the liver does not take place. So, when this does not take place, now liver is going to now try to get the LDL or to take the cholesterol up from somewhere outside. So, what it does is, when it inhibit this, the LDL receptors on the liver here, they get upregulated. So, they will get upregulated. So, when these receptors they get upregulated, definitely they are going to pick up more LDL from the blood. So, what are they going to do? They are going to therefore increase the uptake of plasma LDL. So what will happen eventually? There will be decrease in the LDL cholesterol level. So about 20 to 55% decrease can be seen. So they are very, very good drugs for decreasing the LDL cholesterol. Yes, they also can decrease the triglycerides, but not majorly used for that. But some amount of decrease in triglycerides can be tried with statin as well. All right. Now the action, it takes about 1 to 2 weeks for them to act. So these are one of the best drugs for hypercholesterolemia. Now there are some other effects which are seen with statins, and these are called as the pleiotropic effects. So they have multiple other beneficial effects as well. And what are this? That they can cause decrease in the inflammation. They cause decrease in the platelet aggregation. They can cause decrease in the oxidative stress. They cause decrease in the uric acid levels. They decrease the risk of coronary vascular diseases. Then they increase the nitric oxide production. So these are the various beneficial effects that you can see with statins. Now, some important one-liners about them. So which is one of the most efficacious statins? So I've already discussed that. That is rosuvastatin and atorvastatin. Prodrugs, lovastatin and simvastatin. Most potent, pitavastatin. So pitta is more potent. Longest acting statins. So most of the statins should be given at night because the production of this 𝗙𝗵𝗃-CoA reductase enzyme, they are more efficient at night, except for the longest acting, these statins can be given at any time. So longest acting ones are rosuvastatin and atorvastatin. Least drug interactions. So out of them, pravastatin, it has no CYP metabolism. Therefore, it has least number of drug interactions. So also this is a safe statin for liver disease. It doesn't follow the metabolism in the liver. Another least drug interactive statin is rosuvastatin. Now we move on to the second group of drugs here that we have. That is your resins, bile acid binding resins, which we have is cholestyramine, cholestyramine and cholecalciferol. So what they do is they interfere with the enterohepatic cycling of the bile acids. So they do not allow the bile acids to recycle. So again there will be, you can say that they are required for the cholesterol synthesis. Again there will be decreased cholesterol synthesis. So the similar pattern they follow. Because of the decrease in the cholesterol synthesis in the liver is going to try and increase the receptors on it, and this is going to take up the plasma LDL, and hence there will be decrease in the LDL levels, right? So this drug, resins, again they are doing the same work as statins, but where do we use them? We use them in case of hypercholesterolemia, in case of pregnancy, because statins are contraindicated here. So in case of pregnancy and children, we will prefer to use these drugs. What are the major drawbacks here? They can cause increase in the triglyceride levels. They can cause constipation. And not only the bile acids reabsorption suffers, they also can decrease the absorption of other vitamins. So deficiency of those vitamins can occur. Okay. So moving on to the next drug group that we have, that is the fibrates. So fibrates, we have fenofibrate, 𝗕𝗵𝗎𝗄𝗏𝗔𝗟, and we have one another, 𝗲𝗏𝗡𝗡, right? So what are these? These are PPAR alpha stimulants in the endothelial cells. So what is the role of PPAR alpha in the endothelial cells? They are going to, when you stimulate them, they stimulate the lipoprotein lipase. The role of lipoprotein lipase in the endothelial cell is to cause degradation of the triglycerides. So when they stimulate this LPL, more of triglycerides will be broken down. So they are going to bring down the levels of mainly the triglycerides and then also of the VLDL. So their main indication is hypertriglyceridemia. So their drug of choice for hypertriglyceridemia. Okay. Side effects, very important. Their main side effects, number one is myopathy, especially more common with 𝗕𝗵𝗎𝗄𝗏𝗔𝗟. Therefore, 𝗕𝗵𝗎𝗄𝗔𝗟 is never recommended to be given along with statins, because statins also cause myopathy. So both, if you use them together, they will have more of myopathy. As compared to this, 𝗙𝗵𝗎𝗄𝗏𝗡 is safer. You can give 𝗙𝗵𝗎𝗄𝗡 with statins. Number two is that they can cause gallstones. Then we have niacin. So niacin in high dose is used as a hypolipidemic drug because it inhibits the lipolysis in the adipose tissues, right? So lipolysis is inhibited and it decreases the synthesis of LDL basically, because then it is no longer available for the formation of the LDL. Now this niacin has another property that it can cause maximum increase in the HDL levels. So this drug causes maximum increase in the HDL levels. So where do we use them? In case of dyslipidemia, especially with increase in the decrease in the HDL levels, right? But because of this high dose of niacin, a lot of side effects also occur. So major, number one side effect is flushing. Now this flushing is because it can cause increase in the prostaglandins. So therefore, what is the treatment of flushing? Is either you give a prostaglandin synthesis inhibitor like COX inhibitor, we have aspirin. And there is another drug which is called as 𝗲𝗏𝗡𝗏. This is a prostaglandin receptor antagonist. Prostaglandin antagonist. So it is PR, prostaglandin antagonist. So these two. Number two, it can cause increase in the uric acid levels, and therefore it should not be given to people or patients who already have gout. Then it can cause hyperglycemia. Okay. Then we have another drug which is 𝗍𝗔𝗍𝗍. Now 𝗍𝗔𝗍 inhibits the special transporter NPC1L1 in the intestine, and what this does is it will block the cholesterol absorption. Again, the liver is going to have deficiency of this cholesterol, and again it is going to try to take the LDL from the blood or the plasma. Similar mechanism later on. So what is the main use of this drug? It is like an add-on. So when statins are no longer sufficient, so what you do, you add on this drug. So they are add-on to statins, right? In case of to decrease the LDLs. Major drawback here is steatorrhea. Okay. Yeah. Next one we have, very important, PCSK9 inhibitor. You just asked in the question. So this is 𝗪𝗏𝗡𝗵. So these are monoclonal antibodies. 𝗪𝗏𝗡𝗵, and an antisense oligonucleotide is serine. So all these, any drug with serine, it is an antisense oligonucleotides. So what they do, they prevent the receptor degradation. So on the liver, we had these receptors for the LDL receptors. What is their role? they take up LDL from the plasma. So PCSK9 is involved in the degradation of these receptors. So if the receptors are degraded, then LDL will not be able to be taken up in the liver. So what they do, they inhibit this PCSK. So there is no degradation of these receptors. So therefore more LDL can be taken up. So again, ultimately what they're going to do, they are going to decrease the LDL levels. They are very, very good drugs in causing the decrease in the LDL levels currently. Again, these are add-on to statins, especially in people who have high risk of ASCVD. Then we have bempedoic acid, another very, very exam favorite these days. What is bempedoic acid? Now remember, so this is the liver, and in liver there is formation of cholesterol. So there are two steps for cholesterol synthesis. First step is this citrate, it converts into HMG-CoA, and then HMG-CoA then first to mevalonic acid, ultimately into the cholesterol. So the enzymes, two enzymes are present here. Here we have the ACL and here we have the HMG-CoA reductase. So at this first step we've already done that this step is targeted by statins, while the first step is targeted by bempedoic acid. So they inhibit the ATP citrate lyase. Ultimately what are they doing? They are going to inhibit the cholesterol synthesis. So then the story is the same. So more LDL receptors are going to be, or they are going to be upregulation of this receptor. So more LDL is going to be taken up and they decrease the LDL levels, right? So remember, bempedoic acid, it is a competitive inhibitor here of this particular ACL. Role, so again these are adjunct or add-on to statins. Okay, add-on to statins, or let's say the patient is not tolerating statin, or in statin intolerant patients. Next we have the cholesterol ester triglyceride transport protein, CETP inhibitor. So first, what is the role of CETP? CETP, it helps in barter system of HDL and VLDL or LDL. What is this barter going on? Normally, HDL transfers the cholesterol ester and VLDL gives it the triglyceride. So this is done by CETP. So what will happen when HDL gives it cholesterol esters to VLDL and takes up the triglycerides? They are easily degraded. So therefore what they do, they decrease the HDL levels. While the VLDL ones, they are now becoming rich in the cholesterol esters. So they can become atherogenic. So we need to stop this. So what you do, you are going to block this. So these drugs, anacetrapib and 𝗤𝗏𝗏𝗏, they are going to inhibit this process of CETP. So there's no barter system, exchange system going to occur. So they are going to cause an increase in the HDL and they are going to cause a decrease in the LDL. Next, monoclonal antibodies against ANGPTL3. This is 𝗖𝗵𝗎𝗂𝗏𝗏, another very important drug. Remember this monoclonal antibody, which is angry, ANGL3. So it is going to, what is the role of it? It is going to inhibit the lipoprotein lipase, and lipoprotein lipase is the enzyme which is important for the triglyceride degradation. So if you inhibit this enzyme, there will be increase in the triglyceride synthesis. So what this drug is going to do? This drug is going to inhibit, this ANGPTL3, and so this is going to protect it, or it is going to potentiate the effect of LPL. So there is going to be decrease in the triglycerides levels, decrease in the VLDL levels, and ultimately this VLDL levels is going to decrease in the LDL levels, right? So the target is the LPL. So they are involved in the regulating lipid metabolism. So metabolism of lipids, that is they are going to target here. So they are ultimately going to cause decrease in the LDL also and decrease in the triglyceride also. So remember, this decrease in the LDL, they are doing this without involving the LDL receptor. So which drug group decreases the LDL levels without involving the LDL receptors on the liver? This is the drug. So they have no LDL receptor involvement here. Okay. So where to use them? They are used in familial, again, familial hypercholesterolemia. Hypercholesterolemia. Then we have MTP inhibitors, which is lometapide, and we have ApoB protein inhibitor or antisense oligonucleotide against this, which is 𝗕𝗵𝗎. So both these drugs, or you can say this MTP and this ApoB, both are important for formation of the VLDL, right? So if you inhibit this, there going to be decrease in the production of the VLDL. Ultimately, the LDLs are going to go down. So in case of decrease LDL or decrease LDL here, these are used, right? So MTP. So remember lometapide, MTP. How does it? So it has M, T and P. Metapide. So it rhymes with MTP. And we know mersense. These are your oligosense antisense oligonucleotides. Now, then we have other drugs which are not, you can say, clearly only against the lipids, but they work against like being a hypolipidemic, as well as they have some other work function as well here. So we have this drug which is called as saroglitazar. Remember, this is a dual PPAR alpha and gamma. So here we know that it is going to work against what? So PPR alpha, PPR gamma. So with alpha, it is going to decrease this, the triglycerides. What about the gamma? And they are also going to inhibit, or they are going to increase the insulin sensitivity in the peripheral tissue. So they work both for lowering the plasma triglycerides and cholesterol, along with bringing down the HbA1c. So where they are used? They are used for diabetic dyslipidemia, right? So both lipids as well as the high blood sugar is also targeted because they improve the insulin resistance, and on the other hand, they are lowering the plasma triglyceride levels as such. Now we have another drug which is called as icosapent, which is an ester of icosapentaenoic acid. Now what are the functions of this? So they are going to decrease the VLDL production, number one. Then it also has an anti-inflammatory, number two, and it will stabilize the plaque. Because of this, it causes decrease in the oxidative stress. Remember, important here. So this icosapent, it decreases the cardiovascular mortality, and it can be used as an adjunct to statin in ASCVD, especially if there is triglyceride levels are more than, if triglyceride levels are more than equal to 150. Okay, so these are the important hypolipidemic drugs. The major disadvantage or adverse effect which can be a possibility with this is that it can cause bleeding risk. So increase bleeding risk and atrial fibrillations. So this is an MCQ which was asked. A 60-year-old male patient with history of hypertension, diabetes underwent PCI stent placement for NSTEMI last year. He is currently on aspirin, metoprolol, atorvastatin. Follow-up visit. His lipid profile was follows. So he has everything high cholesterol and LDL cholesterol, total cholesterol, triglycerides, and HDL cholesterol is about 40. So which of the following drugs can be added to optimize his lipid profile? Ezetimibe, evolocumab, bempedoic acid, ezetimibe, evolocumab only, ezetimibe, gemfibrozil and bempedoic acid, or ezetimibe and gemfibrozil only. So remember, he has increase in the cholesterol level, there is increase in the triglyceride levels. So the first answer, all three drugs, ezetimibe, evolocumab and bempedoic acid, they are going to reduce the level of LDL cholesterol, right? Here. So because the cholesterol levels are quite high, you see the total cholesterol levels, LDL cholesterol, it is the best, and the patient has undergone a PCI stent replacement. So what is best to do is that we give all the three drugs together for the patient. So remember here, gemfibrozil, if we add, it is only going to target mainly the triglycerides. Here also triglycerides, right? So therefore, best is that we give all three drugs together. So with this, we finish the hypolipidemic drug. So today we are going to talk about anticoagulants and antiplatelets. So first, I'm going to tell you or take you through the important drugs and classify them. So in the anticoagulants first, we have parenteral and the oral anticoagulants. So in the parenteral anticoagulants, we have indirect and the direct thrombin inhibitors. In the indirect thrombin inhibitors, we have heparin, low molecular weight heparin, fondaparinux and danapiroid. So in the low molecular weight heparins, you have to remember certain names. So all of these will be having a suffix which is your parin. So parins. Even fondaparinux you'll see has a parin image. So you know that it's a low molecular weight heparin or belongs to or is related to heparin. Then we have direct thrombin inhibitors which have bivalirudin and ergatroban. In the oral anticoagulants, we have vitamin K antagonists, especially important is your warfarin. Then direct factor 10 inhibitors like rivaroxaban, apixaban. So they have 10A, right? So you know that it is a 10A ban. It bans it. That means it is an inhibitor of it. Oral direct thrombin inhibitors, we have dabigatran. So now we move further to the first important drug, which is warfarin, the oral anticoagulant. So in this, what does warfarin do? So what is the mechanism of action of warfarin? It inhibits the enzyme VKOR, that is vitamin K epoxide reductase. So it will not allow the reduction of vitamin K to occur. We know that vitamin K is responsible for the activation of the clotting factors 2, 7, 9, 10 from the liver. So when warfarin is given, it will interfere with this process. So there will not be any synthesis or the activation of these clotting factors. So therefore, the anticoagulant effect will ensue. So what are the important things or points you need to know about warfarin? Number one, that when you give warfarin, you don't see an immediate action. Why? It is going to inhibit the synthesis or formation or activation of the newer these clotting factors. But whatever already has been synthesized, that will not be acted upon. So it has a lag period of 4 to 5 days, right? Because it inhibits the newer factors, right? The newer clotting factors. So the first factor which is affected or inhibited is factor 7. The last factor to be affected is factor 2. Now, this is a picture which can be shown as an image-based question in the question as would go by that what is the drug causing this, right? Which drug has caused this? So, answer is warfarin. Now, this is the dermal vascular necrosis which is seen with warfarin, and the reason is that warfarin also initially inhibits the synthesis of protein C, okay? Protein C. This will increase the risk of hypercoagulability, right? It will increase the risk of hypercoagulability initially. So therefore, this problem of dermal vascular necrosis can occur. Therefore, what we do usually is alongside we start heparin also, so that till the time warfarin exhibits the action, you can continue heparin and then later on withdraw. Then next is, what is warfarin used for, or it is a drug of choice for what? So it is a drug of choice for prophylaxis of thrombosis in valvular atrial fibrillation. Mechanical valves. So it prevents the thrombosis whenever there are mechanical waves in the valvular atrial fibrillation. Now, warfarin is a teratogenic drug, so it is contraindicated in pregnancy. Okay. Now, why? Because it can lead to fetal warfarin syndrome. So, this is a picture of a baby whose mother was given warfarin. So, it's a fetal warfarin syndrome. So, there can be this very typical feature, depressed nasal bridge. So, it is a depressed nasal bridge. Then patient can have hydrocephalus. There can be short limbs and digits in the baby. Now, important antidotes to know. So, for warfarin, the important antidote, like if there is an excess of warfarin which leads to bleeding, what can you give? You can give vitamin K. That's the specific antidote. But if it is a severe bleeding, then we also give 4-factor, this precipitate of the plasma, because all these 4 factors, 2, 7, 9, 10, they are the specific factors which are inhibited with warfarin. So, you can give them specifically, but they're expensive then. Right, so it is a specific antidote here is vitamin K. And then for dabigatran, what will you give for dabigatran? The antidote is 𝗙𝗪𝗔𝗍𝗪. Direct factor 10 inhibitors, which is rivaroxaban, apixaban, what will you give? You give andexanet alpha. Again, it contains XA in this spelling. Non-specific antidote for the unfractionated heparin, low molecular weight heparin, fondaparinux, dabigatran is 𝗬𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 Then another picture-based question or image-based question can be asked with this picture. And what is this? This is a purple toe syndrome. Rather, it's a purple foot syndrome. Not only toe, but the whole foot is involved. But the reason is different. Again, this is seen with warfarin. But the reason is there is cholesterol crystal embolization. These crystals, they usually dislodge and then they go and travel to smaller blood vessels. So this is the cholesterol crystal embolization that is seen. Then parenteral anticoagulants. So we will compare the important points in the parenteral anticoagulants. So here we see between unfractionated heparin, low molecular heparin and fondaparinux. So the unfractionated one is, they are very huge molecules, big molecules as compared to low molecular weight, and the fondaparinux has the least molecular weight. Now, unfractionated heparin, it inhibits both 10A and 2A. Low molecular weight heparin has more effect on 10A, while fondaparinux, it only affects or inhibits factor 10A because of the size, Then the routes are usually subcutaneous. You can give unfractionated heparin as such also by the IV route. Risk of the side effects are highest with heparin as such as compared to the others. So what are those risks? The risks are thrombocytopenia, osteoporosis, and this heparin also requires monitoring. So we monitor the APTT, which is not required in case of low molecular heparin and in case of fondaparinux. Now, heparin is a drug which can be given in renal failure as well because it is mainly metabolized by liver. But low molecular heparin and fondaparinux, they are mainly eliminated by kidney. Therefore, these two cannot be given in kidney failure. Please remember this. Then all of them, they are safe or they can be given in pregnancy because warfarin cannot be given, but these can be given. So they are used in various, especially in cases of huge or big surgeries like the cardiopulmonary bypass, we prefer to give heparin, and the other surgeries like DVT prophylaxis, etc. we can give low molecular heparin, or we can also give fondaparinux. So let's see what are the other important features we need to know. In the parenteral direct thrombin inhibitors like valirudin, ergatroban and milagatrin, So they require APTT monitoring. Remember, they require APTT monitoring. 𝗪𝗏𝗄𝗃 is a drug of choice in heparin-induced thrombocytopenia, the HIT syndrome. What is the drug of choice for this? That is 𝗪𝗏𝗄𝗃. But 𝗪𝗏𝗄𝗃 has no antidote as such. Then the antidotes for heparin, it is protamine sulfate, another very important question. But remember, it does not reverse the actions of fondaparinux, only for heparin and low molecular heparin, and more specific for heparin. So they are used, these are used for catheter-induced thrombosis. Side effects of heparin, remember the mnemonic, bleeding hota. So bleeding, H for hyperkalemia, O for osteoporosis, thrombocytopenia, that is the HIT syndrome, heparin-induced thrombocytopenia, for which the drug of choice is 𝗪𝗏𝗄𝗃, and it can cause alopecia. So this is the table telling you about the choice of anticoagulants in various conditions. For example, in pregnancy, in the first trimester, we prefer the low molecular heparin or the heparin as such. Then in the mid 13 to 35 weeks, we can give warfarin, but still we prefer to give low molecular heparins. Then towards the end, that is 36 week onwards, we again will prefer to give, in case warfarin is given in between, we switch on to low molecular heparin. Peripartum, stop the low molecular heparin 24 hours before the delivery, and we resume it after 4 to 6 hours after normal delivery, or 6 to 12 hours after lower cesarean section. Breastfeeding, we prefer warfarin. Prevention of DVT, again you should be giving low molecular heparins. Prevention of stroke and embolism in valves, if the valves are involved, in mechanical valves, we give warfarin. If it is a non-valvular atrial fibrillation, then you give directly acting drugs, orally acting anticoagulants. Then in the DIC, again we are going to give unfractionated heparins. So these are the important choice of anticoagulants in the various conditions. So let's do a MCQ from the previous year. A patient on antiplatelet therapy started complaining of reflux esophagitis, for which he was prescribed omeprazole. After a while, it was seen that the patient suddenly developed slurred speech and numbness in his limb. This was attributed to decreased efficacy of the antiplatelet. What was the most likely drug here? Aspirin, clopidogrel, streptokinase, or 𝗕𝗵𝗏. So the answer here is clopidogrel. So this is now your antiplatelet which has come into picture. We'll see how is the answer correct when we are going to study about the antiplatelets now. So the antiplatelets, the way when you classify these antiplatelets, so one is the inhibitors of 𝗙𝗏𝗃 A2 synthesis, which is aspirin, and this is also in low dose, remember. Then inhibitors of P2Y12 receptor of ADP, we have reversible ticagrelor and cangrelor, and the irreversible we have clopidogrel, prasugrel, ticlopidine. GP2B3 antagonist, we have 𝗵𝗡𝗎𝒪𝒃, 𝗵𝗔𝗓𝒏𝒽𝒃, 𝗘𝗵𝗏. Protease activated receptor antagonist, we have 𝗲𝗏𝗃𝗧. Then phosphodiesterase inhibitor, which is 𝗙𝗵𝗑𝒪𝒧𝒪𝒃. So let's see how they work. Now here I'm going to draw an platelet, let's say 2 platelets. Now how does this all these mechanisms work in platelets? So inside the platelet, the COX leads to formation of 𝗙𝗏𝗃 A2. So when aggregation has to take place, on the other platelet, there is a receptor which is present for 𝗙𝗏𝗃 A2. So this 𝗙𝗏𝗃 A2 released from one platelet is going to act on its receptor, and it is going to cause the aggregation of the platelet. Number 2, what is happening here is the cyclic AMP, it gets converted into the ADP, and this is with the help of phosphodiesterase. So cyclic AMP is anti-aggregatory, but ADP is pro-aggregatory. Now ADP also, when it is released, has receptors on the platelets, and the platelet receptors for ADP here. So this is the receptor for the platelets here that we have for the ADP. This is P2Y12. So when your ADP is going to be released. It is going to act on this receptor here. Again, this is going to cause the aggregation of the platelet. Coming to the GP2B3A. Now, GP2B3A, they are not active as such, but when there is platelet aggregation going to occur, they become activated, right? So, here let's make this is a, so both of these platelets, they have GP2B3A receptors. So, then they are going to stick to each other. So, they are going to stick to each other like glue. So, this is again a method of addition of the platelets, aggregation and addition of platelets. So, all these things are ultimately going to cause aggregation and addition of the platelets where there is injury or where the platelet plug is being formed. So, whatever drugs we are going to give, they are going to block these processes. Then there is another receptor also present here. Oh, here we can draw. This is a receptor which is called as PAR1 receptor. Now, this is receptor where the thrombin binds on the platelets. Again, it is going to cause aggregation here. So, whatever drugs we are giving, they are going to block this. So, aspirin is going to inhibit this step, doesn't allow the formation of thromboxane A2. Then ADP antagonists or P2Y12 receptor blockers, they are going to block the receptor here. GP2B3 antagonists, again they are going to block this, so there's no attraction addition between them. Then we have PAR1 antagonists, they are going to block this receptor. And the last one, phosphodiesterase inhibitor, they are going to inhibit this particular step. So, there will be less ADP formation, more of cyclic AMP formation. And I told you already, the cyclic AMP, this is an anti-aggregator or anti-aggregator. So, it is going to not allow, it is not going to promote aggregation. So, it is, we are increasing the levels of the anti-aggregator. So, this is how these drugs are going to act. So, mechanism of action of first very important is your aspirin. So, aspirin is a thromboxane A2 synthase inhibitor and this is how it works. It inhibits the COX enzyme and it is an irreversible inhibitor of COX, right? Remember, this is an irreversible inhibitor and we call such drugs as hit and run drugs, right? Important. So, in the platelets, it is going to inhibit thromboxane A2, which is actually a pro-aggregatory molecule. So, because these platelets, they do not have nucleus in them, so new thromboxane A2 cannot be synthesized by them. So, new platelets now have to be formed and therefore, this is called as a irreversible action. In the endothelium, if you give a higher dose, what will happen? Why low dose we are concerned with here? Because if you give a higher dose, then it also inhibits the prostacyclins in the endothelium, right? That is, so it is anti-aggregatory. So, pro-aggregatory, anti-aggregatory, both the effects, they will get nullified. And endothelium, the thing is, it can still resynthesize the prostacyclin even if it is being inhibited. But platelets action is basically irreversible here. Now, aspirin is used in stroke, myocardial infarctions, and currently now we prefer to give another antiplatelet along with aspirin, but it's a very, very good drug to be used in these conditions. It is contraindicated if the patient has peptic ulcer and in lactation because it has tendency to cause bleeding. So, in peptic ulcer patients who are at risk of peptic ulcer, we tend to avoid giving these drugs. Then GP2B3A inhibitors, these are considered to be one of the strongest antiplatelet drugs. So, remember the mnemonic T, TEA, tirofiban, eptifibatide, epsiximab. So, all these three are GP2B3A antagonists. Eptifibatide is the shortest acting out of the lot, right? And these can be given easily in renal disease. Then the next we have the protease activated receptor antagonist, that is 𝗲𝗚𝗚𝗏, and it is given in oral form and for MI prophylaxis with aspirin. So, aspirin is a mainstay, you can add on other drugs with it, right? Contraindicated in case of, in the cerebrovascular attacks we don't give, but in myocardial infarction we can give this drug. Then P2Y12 blocker. So, very, very important thing is clopidogrel and prasugrel. So, this is ticlopidine, we don't use that because it has a lot of side effects, but yes, we use clopidogrel. Now, we did in the question before the interaction between omeprazole and clopidogrel. So, what is this clopidogrel? It's actually a prodrug which needs to activate in the body. So, in the liver, there is the cytochrome enzyme CYP2C19 which activates it So until and unless it is not activated, it won't be able to produce the effect. So let's say the patient is being given clopidogrel and you also give omeprazole to this patient, which is a proton pump inhibitor. So what this omeprazole is going to do, this omeprazole is going to inhibit this 𝗲𝗏2𝗲1. It's an inhibitor of the cytochrome. So if omeprazole inhibits 𝗲𝗏2𝗲19, then the clopidogrel is not going to be converted into the active form and it will lead to failure of therapy in that patient. So we should not give omeprazole along with clopidogrel. Secondly, because of genetic variations in individuals, some people might have the 𝗲𝗏2𝗲9, which is not very active, which is very slow, or in some they can be very fast. So in people where the enzyme is slow and not very active, then again the clopidogrel will not be as effective in them as is in the other population group. So instead, because we cannot give omeprazole, what you can give other PPIs who have less of these drug interactions like rabeprazole and pantoprazole. So clopidogrel is best combined with aspirin because it has a synergistic action with it. So these days for percutaneous coronary intervention, we give aspirin plus this clopidogrel. So the dual antiplatelet therapy, even in myocardial infarction now, we give a dual this therapy of aspirin along with clopidogrel. So this is very, very important drug interaction that you should know. Now prasugrel is also a drug, prodrug, but it is activated very, very fast. So in this population or in this drug, this interaction is not very significant because of this, because it's very, very fast. Now remember, it's a very, very potent drug. Now prasugrel is so potent that it can increase the risk of intracranial bleeding in these patients of stroke. So therefore, especially in case of elderly population or people who have a risk of stroke, there we do not give prasugrel, right? So these are the important points which we must know about anticoagulants and antiplatelet drugs, where I will be talking about the antimicrobials, and in that we'll be discussing about the cell wall synthesis inhibitors. Okay, so first let's classify the important antimicrobials based on their mechanism of action. So the first group, we have the ones which inhibit the cell wall synthesis. So we have the penicillins, cephalosporins, vancomycin, bacitracin and teicoplanin. Then the ones which target the cell membrane, we have azoles, polymyxin B, colistin, bacitracin. Third, the ones which target the protein synthesis, aminoglycosides, tetracyclines, macrolides, chloramphenicol, linezolid, clindamycin. Then the ones which inhibit the metabolism like sulfonamides, trimethoprim, pyrimethamine, and metronidazole. Then we have the other mechanisms, for example, suppression of DNA synthesis like it is by rifampicin, inhibition of DNA gyrase, that is by fluoroquinolones, inhibition of DNA or RNA polymerase by anticancer, antiviral drugs, and the drugs which directly can cause DNA damage like metronidazole. Now, out of these drugs, remember that most of the cell wall synthesis inhibitors, they are actually bactericidal in nature. Okay, so the ones which inhibit the cell wall synthesis are cidal in nature. So out of the second group, which causes distortion of the cell membrane, again these three ones, these are cidal in nature, while azoles are static in nature. Now, in contrast, the drugs which inhibit the protein synthesis, most of the drugs, they are bacteriostatic in nature, but then there are exceptions to the rule. So all these are bacteriostatic in nature, except for aminoglycosides, which is cidal in nature. And then there's another group of drugs called as streptogramins, which are also cidal in nature. Streptogramins. Okay. Now, out of the drugs which inhibit the metabolism, so these are like, for example, sulfonamides, trimethoprim, individually, they are static, right? Static if you take them individually. But when they get combined together to form 𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏, this 𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 is cidal in nature. Then similarly, metronidazole also is cidal in nature. Ciproflox, fluoroquinolones, they are also cidal in nature. So all these drugs, these anti-cancers and all, so they target the various cell cycle phases. Again, they kill the cells. So these are the important drugs and their groups, how they are targeting the various sites on the bacteria and whether they are cidal or static in nature. So moving on to the first point here, what we are going to do is the cell wall synthesis inhibitors. So in the cell wall synthesis inhibitors, many a times you are shown this particular diagram, and this is like how the formation of the cell wall synthesis occurs. Now this is inside. You see the cytoplasm written here? So this is inside the cell. From inside to outside, if we go and follow, the step number 1 is blocked by phosphomycin. This is step number 2 by cycloserine. Step number 3 by bacitracin, step number 4 by vancomycin, and step number 5 by beta-lactams from inside to outside. So what are these drugs going to do? So they are going to block the first step and from first to fifth, the last step, right? This is how they're going to act. So easy way, or let's say there's a mnemonic to remember from inside to outside. Remember, first cycle, बाद में is a Hindi word which means later on. बाद में, van, then Land Rover. So this is how we progress in life. First we have a cycle and then we progress to van and then to Land Rover. So what does this mean? First stands for F, that is phosphomycin. Phosphomycin. Cycle stands for cycloserine. बाद में B stands for bacitracin. 1 stands for vancomycin, and Land Rover stands for beta-lactams, land. Okay. So this is how you remember from inside to outside. So in case you're asked to identify, they give you a site and they ask you to identify which particular antimicrobial acts on this particular site. Remember the sequence. Remember, this is from inside to outside. If it is from outside to inside, the sequence would change. All right, so let's do the mechanism of action of these drugs. So if I begin from inside, let's begin from the lower one first, because this is number 1 step, number 2, number 3, number 4, and number 5. So phosphomycin prevents the first step. That means it prevents, see here, the conversion of UDPG to UDPM. Prevents the conversion of UDPG to UDPM. So the first step in peptidoglycan synthesis, right? It's the first step. Now, use of phosphomycin currently it is just used for urinary tract infection. Single dose UTI, that is the only use of phosphomycin. Moving on to the second drug, which is cycloserine. What is the step here? See here. Now, cycloserine, it blocks the conversion of L-alanine to D-alanine, which is we need D-alanine for formation of the peptidoglycan wall. So, D-alanine is not formed. So, it blocks it prevents the conversion of L-alanine to D-alanine. That is the second step it blocks, right? So where it is used use of cycloserine is only in case of MDR tuberculosis. Okay. Coming to bacitracin. Now bacitracin is a topical drug mainly. Right. So where do we use this bacitracin? So here you see the step bacitracin. This bacitracin, it is going to inhibit this BP. This stands for bactoprenol. Now, this is responsible for carrying this peptidoglycan chain towards outside. So, this is because you need to have the synthesis on the outer side. So, this whole chain is carried with the help of BP. So, this is the BP is bactoprenol transporter. So, what does bacitracin do? It blocks the bactoprenol transporter Therefore, it inhibits the transfer of peptidoglycan chain. Okay, stops this peptidoglycan chain from transferring outside. That's the role of bacitracin. Coming on to vancomycin. So what is vancomycin doing? It is inhibiting this particular step here, where it binds to the D-alanine, terminal D-alanine, and doesn't allow it to cleave, right? So because it is important that it leads to, this D-ala cleaves, then there is a release of energy, and then there is actually the formation, the cross-linking then later on by happens. But this is going to block that first step. It doesn't allow the D-alanine. It blocks the D-terminal D-alanine here. So what it does, it blocks or it attaches to the terminal D-alanine and it inhibits transglycosylation. Right? That is the most important. So it is one step before the beta-lactams. Then the terminal step is beta-lactams. So beta-lactams, they bind to the penicillin binding proteins and inhibit the transpeptidation. Remember, they inhibit the transpeptidation and cross-linking. So if there is no cross-linking formed in this particular the cell wall, then they become very weak. The cell wall becomes very weak and it is easy for the cell wall to get destroyed. And therefore, and cross-linking. So beta-lactams consist of your penicillins, cephalosporins, carbapenems, and monobactams. So this is the main role or main mechanism of all these drugs which act on the cell wall, remember, right? So these are the drugs. The first one, beta-lactam. So we have the penicillin G. In the penicillin G with the aqueous form, we have the aqueous penicillin G. We have the procaine penicillin G, which is highly notorious to cause the hypersensitivity reactions. And then we have benzathine penicillin G, which is the longest acting out of the lot. Now, uses of penicillin G, remember a mnemonic here, which is mega drills. DR or drills, we can say. DRALS, mega drills. Okay, so let's see what are these mega drills. So M stands for meningococcal meningitis. So we use this drug as the definitive treatment. For prophylaxis, or you can say for the empirical prophylaxis, we use ciprofloxacin. We can use rifampicin in case of pregnant and women and in children because fluoroquinolones are contraindicated in them. So rifampicin in pregnancy and in children. Then E stands for endocarditis. Streptococcal endocarditis. So here you usually give it along with an aminoglycoside. So beta-lactams are going to cause the breakage or it is going to cause non-formation or it doesn't allow the synthesis of the cell wall and easier for aminoglycosides to penetrate inside. Also, if you see the spectrum, beta-lactams like penicillin, they are most effective against gram-positive while aminoglycosides are more effective against gram-negative. So that is another thing in there. Then G stands for gas gangrene. Then A is anthrax. D is diphtheria. R is rat bite fever. A is actinomycosis. L is leptospirosis and S is syphilis. Now, ampicillin, where it is used? So, ampicillin is used in case of listeria monocytogenes, right? It is the drug of choice here. Amoxicillin in respiratory tract infections and also in some urinary tract infections. Now, very important is treatment of syphilis. Now, remember, depending on the stage of syphilis, we treat primary, secondary, early latent syphilis, late latent syphilis, and tertiary syphilis without involvement of any organ. So, no neurosyphilis, no other organ is involved. In both of these cases, we can use the benzathine penicillin. So, here we use injection benzathine penicillin. Here also we use injection benzathine penicillin. You know, they have a longer half-life. So, longer acting also. So, here in the first case, we use injection benzathine penicillin, 2.4 units intramuscular, but single dose only. In the second case, we use 2.4 million units intramuscular once a week for about 3 weeks. So, we use 3 doses. Now, in neurosyphilis, we can't give benzathine penicillin because we need it to enter the brain. So, here it is no longer effective. So, we use here aqueous crystalline penicillin G, 18 to 24 million units, and you give IV daily. Remember the dose here also for syphilis. Now then we have semi-synthetic penicillins. Now obviously because in the penicillins have a lot of drawbacks, orally they're not very effective, then there is resistance occurs and acid, they are labile. So what we have done is we have created certain semi-synthetic penicillin which can actually address each of these issues. Now acid resistant penicillins that we have, you can say they are classified into various drugs, and we remember a mnemonic vodka. So here acid resistant penicillins. So we have penicillin V, O is oxacillin, D is dicloxacillin, C is cloxacillin, A is ampicillin, and the other one is amoxicillin. So even single I can write as the aminopenicillin. Now extended spectrum. So these are your extended spectrum. So again, another interesting way to remember this is, you remember that they work against extended spectrum against 3 microorganisms. One is Klebsiella, Pseudomonas, and E. coli. So let's see, starting from the first organism, which is your Klebsiella. So against Klebsiella, MAP mnemonic that you remember. So here in the uridopenicillins, we have piperacillin, we have meslocillin. Also, you can add another one, that is azlocillin. So MAP stands for, so this is MAP, M-A-P. Now this is effective. So these 3 drugs, they are effective against Klebsiella. Now, CT-MAP, bring in more penicillins here. CT is this one, CT. So CT-MAP is now effective against Pseudomonas. Right? So this was only effective. So this is MAP, this is CT-MAP. And then bring in aminopenicillins also. So this is ACT-MAP. So A here stands for the aminopenicillin. So this is effective against E. coli. Easy way to remember, MAP is against the MAP. The drugs are against Klebsiella, that is meslocillin, piperacillin, and azlocillin. CT-MAP, that means MAP plus CT, carbenicillin, ticarcillin, also against Pseudomonas. When you add A, aminopenicillins, they're also all effective against the E. coli, right? So this is the way to remember these drugs. Alright. Then we have beta-lactamase inhibitors. Now, what are beta-lactamase inhibitors? We know that many organisms, they now secrete beta-lactamases. So these are going to destroy the beta-lactam antibiotics. So resistance develops to these drugs. So what we do, we give beta-lactamase inhibitors along with these drugs. So for example, with amoxicillin, we give clavulanic acid. With ampicillin, we give sulbactam. With piperacillin, we give tazobactam. And tazobactam is also being given with a cephalosporin, which is ceftriaxone. So what is the role of these beta-lactamase inhibitors? They are not antimicrobials as such. What are they? These are called as suicide inhibitors. So they are suicide inhibitors. Their role is just to inhibit beta-lactamases so that the antimicrobials, they can do their role. So they just inhibit the beta-lactamases. They are suicide inhibitors. So why do we have a particular beta-lactamase inhibitor with a particular beta-lactam antibiotic? Is because they have some matching pharmacokinetics. That's why they are used. Then we have some newer examples of these drugs, suicidal inhibitors along with beta-lactam inhibitors along with the other drugs. For example, with meropenem, we have 𝗣𝗿𝗸𝗀𝗡. With ceftazidime, we have 𝗖𝗵𝗎𝗏𝗡. And with cefepime, we have 𝗫𝗏𝗡𝗏. So these are some newer combinations which are in market and you should be knowing about them. All right. From penicillins, we move on to cephalosporins. So cephalosporins are classified into 5 generations. So remember here in 5 generations, the first generation, they usually end with Pha or PHA or FA, right? Most of them, they have in the spellings either Pha or PHA. Exception to the rule is cefaclor. It is under second generation, even though it has a Pha in that, but it doesn't belong to first generation. That's the only rule. Second, don't need to remember. You move on to the third one. In the third ones, they end with either 1 or 10 or ine. 1, 10, ine. So they end with this. So ceftriaxone, ceftibuten, ceftazidime, cefpodoxime, cefixime, cefoperazone, etc. Then fourth generations, they have pi in their spellings. And the fifth ones, they have rho in it. That is anything which is left, it will belong to second generation. Remember, the second generation drugs, these are not used. Clinically, they're not used. Okay. Now, from first generation to the fifth generation, the spectrum also changes. So, first generation is mostly effective against gram-positive organisms. So, as you move on, the second generation, they have more effect against gram-negative. Some are even effective against Pseudomonas. Fourth generation also, they are quite effective against Pseudomonas. Then fifth generation, these are the only beta-lactams which are effective against MRSA, right? So from gram-positive to the varying organisms like Pseudomonas, even ESBL, so they are effective against them. Now, out of the first generation, the important drug that you have to know is cefazolin, which is the drug of choice for surgical prophylaxis. Okay. Then third generation, the most important drug groups here. Now, cefixime, this is the oral drug of choice for typhoid, while ceftriaxone is the IV drug of choice for typhoid. So ceftriaxone is a very, very important drug. So it has other uses as well apart from typhoid. It is also used in meningitis as empirical treatment. Remember, this is an empirical treatment. Penicillins are the definitive treatment, and with prophylaxis, we have ciprofloxacin or rifampicin. Remember that, right? And also they are used in, drug is used in gonorrhea. Okay, so these are the important points here from the group. Now let's do some other classical examples that are asked, or the points which are asked. Which cephalosporins are effective against Pseudomonas? So the drug of choice, we have ceftazidime, and we combine it with an aminoglycoside in case of severe infection. Severe infection. The other drugs which are effective against Pseudomonas we have from the third generation is 𝗲𝗄𝗏𝗡razone. From the third generation, we have ceftazidime, 𝗲𝗄𝗏𝗡razone, which is effective. And the fourth generation, cephalosporins, both of them are effective. Right? And we've done a combination here, ceftolozane and tazobactam, this one. This is also anti-pseudomonal. So, tazobactam with ceftolozane. So, tazobactam with ceftolozane. So, all these are effective against Pseudomonas. Then, which of the cephalosporins are safe in renal failure because they're secreted in the bile? So, again, we have ceftriaxone and 𝗲𝗄𝗏𝗏𝗡razone. Ceftriaxone also causes pseudolithiasis. Then disulfiram-like reaction or hypoprothrombonemia, it is caused by cefamandole, then 𝗲𝗄𝗏𝗏𝗡razone, then cefotetin and moxalactam. Moving on to the next group here in the beta-lactams, we have 𝗘𝗵𝗆. So, in the 𝗘𝗵𝗆s, we have meropenem. So, all these will be penems, meropenem, imipenem, 𝗲𝗵𝗆, doripenem, ferropenem. So, their spectrum, if I talk about, they have a broad spectrum. So, they are effective against gram-positive, gram-negative organisms, Pseudomonas, ESBL, as well as ANRO. For these serious infections, we give them. Now, ertapenem is the only carbapenem which doesn't have a good activity against Pseudomonas. So, we can say this is not very active against Pseudomonas. Not active against Pseudomonas. Ferropenem is the carbapenem which is available by the oral route. Others are parenteral. This is the one which is available by the oral route. Now, imipenem has a very short half-life because it gets degraded by dehydropeptidase. So, if you give imipenem as such, it will be immediately degraded with have a short half-life. So, what do we give? We give it along with a drug called as cilastatin, which is inhibitor of renal dehydropeptidase. So, because of this, it will prolong the half-life of imipenem. So, what will happen? There will be increase in the half-life of imipenem. It's not required with the others, but with imipenem especially it is required. Other problem with imipenem, what is the other side effect or the adverse effect with this imipenem is that it can cause seizures, right? Seizures is one of the important side effects. Then monobactam. So, monobactam is different from the other beta-lactams because it has a single ring. Single beta-lactam ring. The name is estrionam. Because of this, there is no cross allergy. So, if you give a beta-lactam and patient develops allergy to that or hypersensitivity reaction to that, you cannot give any other beta-lactam except for monobactam you can give because it has a structural difference from these beta-lactams and can be used in case of if there's an allergy with those drugs. So, it has no cross allergy as such. But remember, its spectrum, that it is only for gram-negative organs. That you have to prove. Now coming to the various drugs for MRSA, methicillin-resistant Staph aureus. So remember what happens is when you give a beta-lactam drug, so bacteria, they are intelligent, they start developing or they are making beta-lactamase to escape attack from beta-lactams. Now for beta-lactamase, we made drugs like methicillin, right? Or cloxacillin, all those drugs. But organisms develop resistance, they formed methicillin-resistant Staph aureus. Then for this, you made a drug, vancomycin. But organisms, they became more intelligent and they developed vancomycin-resistant Staph aureus. Now for this, you have two types of treatment. So you give two types of drugs. One is daptomycin. You can give it, but if it is VRSA associated with pneumonia, then you can't give daptomycin. Then you give linezolid. You can't give in pneumonia daptomycin because what happens is there is degradation of this daptomycin by the surfactant in the lung. So it won't be effective. So you give linezolid. So this is a table that you should know. So here for MRSA, IV vancomycin is the drug of choice. We can give other drugs like, so other drugs which we have, we just now did that 5th generation cephalosporins can do the trick. Then we can give linezolid as such. We can give teicoplanin also, teicoplanin, and we can give streptogramins. Topically, for this MRSA, you can give mupirocin or bacitracin. For VRSA, I said drug of choice is daptomycin. But in case of pneumonia, we can't give daptomycin. So here you will have to give linezolid. Then for extended spectrum beta lactamases, what is the drug you can give? That is 𝗙𝗵𝗫. 𝗙𝗵𝗫. Then if bacteria develop resistance to this as well by forming carbapenemase, what can you give now? You can give tigecycline or polymyxin. Okay. So what are the different drugs used for Pseudomonas? Important. So the drug of choice you have discussed, aminoglycosides plus ceftazidime. Then you can also give colistin. You can give polymyxin B. Then we have various fluoroquinolones which you can use, ciprofloxacin. We can use levofloxacin. Then we can use carbenicillin. We can use ticarcillin. We can use piperacillin. Okay, then we can use carbapenems. We can use monobactams. We can use 4th generation cephalosporins, right? And we can use cefoperazone. So these are the drugs which can use for treatment of pseudomonal infections. All right. Coming to another very important topic, it is vancomycin. So vancomycin was blocking the step just before the beta-lactams. So where do you think we can use them? So it is used only in case of a condition which is called as pseudomembranous enterocolitis. So this is a picture which shows pseudomembranous enterocolitis. This is caused by an organism. It's an opportunistic infection or superinfection and caused by the organism Clostridium difficile. So which are the drugs which have more tendency to cause this infection? So we have 3rd generation cephalosporins. Then we have aminopenicillins and clindamycin. So they have a tendency to cause this. The drug of choice which we have for this condition is fidaxomicin. We can use vancomycin, but the drug of choice is fidaxomicin. We have some newer drugs also like bezlotoxumab and ridinalazole. So these are the newer drugs that you should know. Vancomycin IV. So this was orally when we use by the oral route. So where do we use for the IV? We just now did for the MRSA. We use it, and even for toxic shock syndrome. Right? So what is the drug used for prophylaxis of MRSA? So here we use topical mupirocin or bacitracin you can use. Bacitracin. Now remember, vancomycin is not effective against please remember, it is not effective against Pseudomonas. Most common side effect which is seen is a maculopapular rash. Maculopapular rash. Now, vancomycin, if we give it very fast by IV route, it leads to a condition called as red man syndrome because of the release of histamine. So, because of the release of histamine, so when you give very, very fast IV infusion, it appears within 4 to 10 minutes. So, how can you prevent it is by giving IV infusion at a slow speed, right, over a period of time. Or you treat with an antihistaminic drug. So, or you give treatment of beforehand only you give an antihistaminic, and it definitely needs dose reduction. So this is the condition, this is called as red man. So you see the redness, the whole patient, he turns red, he or she. So this is called as the red man syndrome. It can be an image-based question as well. Then currently lately it was asked what is the scale for vancomycin dosing. So just remember the scale. It's called as Matzke normogram scale. Okay. Now, drugs acting on the cell membrane, we have daptomycin. It forms pores on the cell membrane and leads to potassium ion efflux. So, this is a drug of choice for VRSA, except pneumonia, right? Except pneumonia, where we give linezolid. It is also used for VRE infections. Colistin is used for a condition which is called as superbug or New Delhi metallo beta lactamase, right? Organism is New Delhi metallo beta lactamase. It is used in the superbug. It is used, and it can also be used for Pseudomonas. So basically, it's used for multi-drug resistant gram-negative bacteria. That's the role of or use of colistin. So with this, we finish with the drugs acting on the cell wall synthesis and the cell membrane. And today I'm going to discuss in pharmacology about the antimicrobial drugs, the drugs which are going to inhibit the protein synthesis and the ones which act at the level of the DNA gyrase. So let's get started. So first we are going to do drugs which are acting on the protein synthesis. So this is how the protein synthesis actually works or functions. So we have this mRNA and we have the 50S here and the 30S ribosomes of the bacteria. And the tRNA, it brings in the new amino acids for the proteins to be formed. So we have this 2 acceptor and the peptide side where the protein is being synthesized. Now, the various targets that we have via antibacterial drugs are going to act on the different levels here, right? So this is the first step where the new amino acid, it will bind to the acceptor site. Then after it binds here to the acceptor site, there is movement of the amino acid chain from the P site to the A site, and this we call as transpeptidation. Transpeptidation. peptidation. Then after this, there is when the mRNA moves and these ribosomes, they glide over the mRNA. So there is shifting of this A and the P site, and a new A site here is revealed, while the older chain, it becomes now the oldest A site now becomes the P site. So this is called as translocation, right? So we are going to do the various mechanisms by which the antimicrobial drugs are going to target different steps here. Before that, see, I told you there are two subunits, 50 and 30S. Now, we sometimes are asked which are the antimicrobials which are targeting the 30S and which antimicrobials are targeting the 50S. So, let's see and remember an easy mnemonic for this. So, mnemonic to remember for this is by at 30 and cells at 50. So, here you just remember the uppercase alphabets, right? Uppercase alphabets, and we are going to then remember the drugs from here. So for the first AT, A stands for aminoglycosides, T stands for tetracycline, and tigecycline. From the cells here, C stands for chloramphenicol and even clindamycin. Then E stands for erythromycin and the other macrolides. L stands for linezolid, and S stands for 𝗕𝗵𝗃𝗓. Then, so here we have the target site, whether it is 30S or the 50S ribosomes. Now we are going to actually discuss the actual mechanism of actions of these. So the first drug we have aminoglycosides. Now these are cidal drugs, bactericidal drugs. So what they do, they block the initiation, then they prevent the polysome formation, and they cause misreading of the amino acid. So when the wrong amino acid is incorporated, so the proteins which are going to be formed are going to be defective. So they are therefore cidal drugs. Tetracyclines, tigecycline, rest all of these drugs, they are static drugs, except for aminoglycosides and 𝗲𝗏𝗏. Normally, all the drugs which inhibit the protein synthesis are static drugs. Exceptions are aminoglycosides and 𝗲𝗏𝗏. Then we have tetracyclines and tigecycline. So what they do, they are going to inhibit the attachment of tRNA. The first step here, when this tRNA brings in the new amino acid, so T for tRNA, T for tigecycline and tetracycline, they inhibit this first step, okay? Alright, then moving on to the third group of drugs that we have is chloramphenicol. So chloramphenicol, it prevents the transpeptidation, right? The process where there is shifting of the whole peptide chain onto the A side. Then macrolides and clindamycin, they prevent translocation. So they prevent translocation. Linezolid, remember, it has a very peculiar binding site as compared to the others. It binds to the 23S fraction of the 50S ribosome, right? So it does not allow. So there is no formation of the initiation complex. The initiation complex is only not formed. No formation of initiation complex. Then we have streptogramins. So they are made up of two drugs. So one is quinopristine and we have dalfopristine. This is present in 30:70 ratio. So what the first drug is, it will inhibit the early phase. They inhibit the early phase of protein synthesis, and it also inhibits the second drug. It inhibits the translocation. So individually these drugs might be static, but because they are combined together they become cidal drugs. So these are the various mechanisms of the drug which act on the protein synthesis. So moving on to the important aspects of each one of these drug groups. So first, very important, is aminoglycosides. Now aminoglycosides, these are, as I told you, bactericidal in nature, and they are specifically active against the gram-negative bacteria, even against the Pseudomonas. But what are they not active against? So they are not active against anaerobic organisms, anaerobes, and gram-positive organisms, because they require oxygen for entry into the organism. So if there is no oxygen, like in anaerobes or in anaerobic conditions like in this pus and all, so they're not going to be very, very effective. Now, which is the most common resistant mechanism? Resistance is acquired by the organisms by which mechanism? Which is the most important is enzyme or enzymatic inactivation, right? So this is the most common resistance mechanism, but it is not seen with the drug amikacin. Therefore, it's a broad spectrum and there is less resistance, yes, to this particular drug. Now, aminoglycosides have important toxicities. So three important toxicities which are seen with aminoglycosides. It is ototoxic, it is nephrotoxic, and it is neurotoxic, right? Remember, ototoxicity is dependent upon the concentration. Nephrotoxicity is usually dependent, it shows the time. So it is, ototoxicity means higher the concentration, more will be the concentration of the drug in the ear and ototoxicity occurs. And nephrotoxicity is usually time dependent, right? Neurotoxicity is because it will inhibit the calcium entry and therefore decrease the acetylcholine release. That's the logic of it being neurotoxic. Therefore, it is not given along with neuromuscular blockers as such. So, which is the most nephrotoxic drug? Out of these drugs, we have neomycin and gentamicin. Remember, these drugs are nephrotoxic. So, whenever there is, you always have to check for the creatinine clearance. And if it is less, you will have to decrease the dose of the drug if it is absolutely required, this particular drug. So in elderly patients where already there is a decrease in creatinine clearance, we prefer not to give this as a first line drug, but in case it is important, you have to comply with the creatinine clearance and then calculate the dose. It has to be decreased and never combine it with another nephrotoxic drug. For example, we have vancomycin, right? Amphotericin B. We should not be combining these two. Then most ototoxic. Now, ototoxicity again, it is of two types. One is auditory, other is vestibular. Remember, it can cause deafness and which is irreversible. Nephrotoxicity is reversible once you stop the drug, but ototoxicity, if the hearing deafness occurs, hearing loss occurs, that is irreversible. So auditory, which is the most ototoxic, A for auditory, A for amikacin. And vestibular, we have streptomycin. Okay. So avoid giving this drug in patients who have myasthenia gravis because they already have weakness of the muscle. So if you give this drug, because they're going to decrease the acetylcholine release, they're going to aggravate myasthenia gravis. So avoid giving in myasthenia gravis patients and with neuromuscular blocking agents, because that will also aggravate the condition. Now, absolute contraindication also exists for pregnancy. So we do not give this in pregnancy. It's a teratogenic drug. What are the uses? Let's do the uses now. So in case of plague, tularemia, tuberculosis, so here we are using streptomycin. Then in tuberculosis, right, second line drug, we can use streptomycin, reserve first line actually. Then we have 𝗕𝗵𝗄𝗡, kanamycin, etc. These drugs are there. Then endocarditis. This is used along with penicillin. Remember, penicillin breaks the wall, cell wall, and allows aminoglycoside to enter. Mixed infections also it is very important, because penicillin takes care of the gram positive and this will take care of the gram negative. Then for pseudomonas infections, you give aminoglycosides along with ceftazidime plus aminoglycosides, right? Gentamicin, tobramycin works. Gentamicin and tobramycin. Now, remember, another important thing about this drug is that these, if you give it orally aminoglycosides, they tend to get ionized. So because of this, they tend to get ionized. So they are not absorbed. They are not absorbed orally because it gets ionized, and you know that ionized fractions do not get absorbed. So they have to be given by a parenteral route, like intermuscular, right? So can we still use them by oral route? Yes. If you only want the local action, you can still use them by the oral route or through the oral route. Where is it used? So we have a drug called as neomycin. It is used orally for gut sterilization. So you read the action in the GIT, in the gut only. So gut sterilization. Then oral paramomycin. We can use this in case of intestinal amoebiasis. Again, the target is in the intestine itself. All right. Moving on to the next group of drugs we have is tetracyclines. Now, these drugs, the most common resistance mechanism here as compared to aminoglycosides, here we have the efflux mechanism. Efflux mechanism. Okay. Now, the important uses, how you can remember, we can remember a mnemonic: lymph scar. Remember, lymph scar. So, it can be used in lymphogranuloma venereum. Then it can be used in SIADH. We use the meclocycline. C stands for chlamydia cholera, and we can use doxycycline. A stands for atypical pneumonia. Though drug of choice is macrolides, but you can use them, atypical pneumonia. And R stands for rickettsia. Again, we can use doxycyclines. Even we use it in 𝗙𝗏𝗏𝗏 fever. Okay. So S can also stand for 𝗙𝗏𝗏𝗏 fever. Now, very, very important are the adverse effects. So they have a lot of adverse effects also. So all the tetracyclines, they are contraindicated in case of kidney disease, except for doxycycline. So this is the only tetracycline which can be given safely in renal diseases. Now we have another mnemonic to remember the ADRs of tetracycline, and we can remember easily by tetracles. Easy? Tetracles, tetracycline, tetracles. Okay. Now T stands for teeth turn yellow. So you see here, there is discoloration of the teeth, yellowish discoloration of the teeth, ill-formed, and they are discolored. E stands for, can cause epigastric distress. Another T stands for, it is teratogenic, because it can cause bone and teeth defects in the fetus. R stands for, it can cause renal toxicity. There is a condition called as Fanconi syndrome seen with expired tetracyclines. Also there can be rash. Then A stands for, so A stands for ADH release is inhibited. C stands for chelation is seen with iron and calcium. So they should not be given immediately together, right? We need to keep a gap of at least 2 to 4 hours. Then L stands for liver toxicity. So L stands for, it is hepatotoxic potential, there is liver toxicity. Another E stands for ear toxicity. So it has a feature of oral toxicity as well, and the drug is minocycline. And S stands for superinfection. So all the broad spectrum, tetracycline is a broad spectrum antimicrobial. So usually all the broad spectrum antimicrobials, they have this problem of causing the superinfection. So they are used for one type of infection, and because they are going to suppress the intestinal flora, the good bacteria, so they lead to superinfections in the patients. So tetracyclines as well as the chloramphenicol, they have this issue. Now coming to tigecycline. Now tigecycline is given only IV, and again it's a broad spectrum drug. Just like tetracycline, it's a broad spectrum drug, and it is safe in kidney disease. Unlike them, it is safe in kidney disease. So it can take care of MRSA also, tigecycline, and VRSA. Then we have some newer tetracyclines like 𝗍𝗏𝗡, which can be given IV for intra-abdominal infections. Intra-abdominal infection. Omadacycline can be given IV, can be given oral for community acquired pneumonia. Then we have sarecycline, can be given orally for acne vulgaris. So these are some of the newer tetracyclines. The next we have is chloramphenicol. Now this is one drug we don't use as such, and its adverse effects are more important as compared to those uses. So the question is usually asked on its adverse effect mostly. So what is the major or important area associated with this? It's called as the gray baby syndrome. See the baby here, the baby turns gray in color. It is called as the ashen gray color cyanosis. That's why we call it as a gray baby syndrome. So why is this gray baby syndrome occurring? Because in neonates, especially in the premature neonate, if you give chloramphenicol, their enzymes, the liver, they are not very well developed to metabolize chloramphenicol. Even their kidneys are not very well developed so that the drug can be excreted. So there is increase in the levels of chloramphenicol in the blood, and that leads to this toxicity. So this is because of the immature liver enzymes, number one, and number two, there is due to the immature excretion pathway. The kidneys are still developing in that child. That leads to gray baby syndrome. Then chloramphenicol also causes bone marrow suppression. Now there are two types of bone marrow suppression. One is type A, one is type B. In type A, it is dose dependent. We know that this is occurring in this patient. It is reversible as such. But type B, we are more worried about because this is idiosyncratic. Right? Type B means idiosyncratic. Any kind of dose can trigger this, leads to aplastic anemia, and therefore this is very, very dangerous. Because of these side effects, we do not prefer to give it to the general population. So we have better drugs available, safer drugs available, so we don't use them anymore. All right. Then we have macrolides. The third group here we have today is macrolides. So macrolides we have azithromycin, roxithromycin, and erythromycin. So the uses of these macrolides in pertussis and in diphtheria, we use erythromycin. Erythromycin. For atypical pneumonia, the drug of choice is macrolides, especially we use azithromycin. Gonorrhea, drug of choice is 𝗪𝗏𝗏𝗏. But we can add azithromycin. Toxoplasmosis in case of pregnancy, we use 𝗲𝗏𝗏𝗏. H. pylori, we use clarithromycin. Okay. Now, ADR is important. Again, we have a mnemonic called as macro. M-A-C-R and O. So, macro stands for motilin receptor stimulation, which can lead to increase in the motility of the intestines, and it can trigger loose stools. Then A stands for allergic reactions. Allergic reactions. C stands for cholestatic jaundice. It is mostly seen in case with erythromycin. Right? And RO stands for reversible ototoxicity. Again, mostly seen with erythromycin group. Now, nifedromycin actually, it is made in India. Made in India. That is important. It binds to 50S ribosome. Binds to 50S ribosome. And what is the use? In case of drug resistant pneumonia. Use is in drug resistant pneumonia. Then clindamycin, important things to know about clindamycin. It can cause, that means you're using clindamycin, but what it can cause, it is one of the drugs which is known or implicated in the causation of pseudomembranous enterocolitis. Remember, clindamycin can cause, third generation cephalosporin can cause, then aminopenicillins can also cause. And what is the treatment of pseudomembranous enterocolitis? The drug of choice we have fidaxomicin. We can also give vancomycin, right? It is hepatotoxic, yes. And what are the uses of clindamycin? Number one, it is used for anaerobic infections, but where? Above the diaphragm. That is supradiaphragmatic, like in the lungs and the brain. So we use it here. And number two, it is used for toxic shock syndrome. Coming to the next drug, we have linezolid, torozolid, and radasolid. Now this is important. It binds to 23S fraction of the 50S ribosome. We've already done that. So where it is used, it is a drug of choice for VRSA pneumonia, because otherwise we can use daptomycin, but daptomycin, it cannot be used in VRSA associated with pneumonia because that gets inactivated by the surfactant in the lung. So there we use VRSA, we can use it in VRE as well. ADRs of linezolid, that it is a MAO inhibitor, therefore it can lead to serotonin syndrome. Serotonin syndrome, especially with drugs which increase the level of serotonin, right? With the drugs increasing the serotonin levels. Then it can also therefore trigger cheese reactions, and it can cause bone marrow depression. Streptogramins, quinopristine, dalfapristine, 30:70 ratio. So it is also used for MRSA, VRSA, and VRE. Then we have tacrolimus. Now tacrolimus is not used in antimicrobial. It is a macrolide, but it has a very good immunosuppressant action. So it is used in cases of organ transplant. So we are going to do them when we do the immunosuppressant drugs. So fidaxomicin is a macrocyclic antibiotic. Macrocyclic antibiotic used for pseudomembranous enterocolitis. Alright. Then we have drugs which are going to inhibit the DNA gyrase. They are called as fluoroquinolones. So these are again bactericidal drugs. So what they do? They prevent the negative supercoils and inhibit replication by targeting DNA gyrase. So remember, the replication takes place like this, and the bacteria need to unwind, right? So this is, there's a nick or a cut which is given by DNA gyrase. But if you block this DNA gyrase, then the cut won't be visible. Then the bacteria will undergo extensive supercoiling like this, and ultimately the strands are going to break like a rope. You see, like if you cannot unwind a rope, then if you pull the two ends of the rope, they are going to get so tightly coiled. So this is the same thing happens to the bacteria, and therefore it can lead to the death of the bacteria. Now, which fluoroquinolone has the maximum oral bioavailability? And the drug is levofloxacin. Drug which causes maximum QT prolongation, maximum seizures. So remember this max. Max rhymes with mox. So it is moxifloxacin. Which of the drug is safe, of the fluoroquinolones are safe in renal failure? So this is PMT drugs. PMT drugs stand for P-floxacin, moxifloxacin, 𝗤𝗏floxacin. Now remember, this is banned. Why? Because it was hepatotoxic. Maximum CNS penetration which can enter into the brain, that is P-floxacin. P size, small size, it can enter into the brain. Uses. First use, respiratory diseases. For example, in the MDR tuberculosis, we use respiratory fluoroquinolones. So, which are these respiratory fluoroquinolones? Remember, OMGL. Oh my God, Lord. Right? Oh my God, oh my good Lord. Whatever you want to remember. So, oh my good Lord. So, we have O-floxacin, moxifloxacin, 𝗤𝗙𝗏floxacin, and 𝗙𝗵𝗆floxacin. Then a good fluoroquinolone for UTI or traveler's diarrhea, we have norfloxacin. Now, ciprofloxacin is very important fluoroquinolone. It is used in a variety of conditions. Number one, it is used for chemoprophylaxis of the contacts of meningococcal meningitis of these contacts. Number two, it is used for anthrax. Number three, it is used in typhoid. And number four, it is the only drug, oral drug rather, for pseudomonas, right? Only oral drug for pseudomonas. Adverse effects. Increase in the QT interval. Another important thing, again remember, increase in the QT interval. So what is it? Maximum. Remember the word maximum, that is moxifloxacin. Phototoxic. Maximum phototoxicity is seen with spare the sun, 𝗲𝗏floxacin. Right? So you have to spare the sun. Do not go in the sun directly when you are under the influence of these drugs. So spare, 𝗲𝗏floxacin. Again, these are contraindicated in case of pregnancy and in case of children. So these are some newer fluoroquinolones that we have. Prulifloxacin, it is given for urinary tract infection. Pazufloxacin, it is very effective or good against the pseudomonas. Balofloxacin, again given for UTI and RTI. Dilafloxacin, D is dual. Two things it does. It is working against the MRSA as well as pseudomonas. 𝗲𝗏floxacin against the RTI. So we have Pruli, Pazo, Balo, Dila, and 𝗲𝗏floxacin. So floxacin, whenever it is, you all understand it's a fluoroquinolone, right? So mostly it will be about the ones which are active against pseudomonas. So it is pazufloxacin and dilafloxacin. So with this, we are finished with the drugs which are going to inhibit the protein synthesis and the ones which are going to inhibit the DNA gyre. Today I am going to talk about anti-TB and anti-leprosy drugs. So this is the structure or the image showing the target sites of various anti-tubercular drugs, the first line drugs. So here we have isoniazid, which are targeting the mycolic acid synthesis of the cell wall. Then we have ethambutol, which inhibits the arabinogalactin synthesis again in the cell wall, ultimately inhibiting the mycolic acid only. Then we have rifampicin and the drugs like rifabutin, which is targeting the RNA polymerase, and then we have pyrazinamide, which also targets the cell membrane. We'll be discussing how. Now, the important question apart from the mechanism of action of these drugs is they often ask you, what is the mechanism of resistance? Which genes are responsible for resistance occurring in the mycobacteria? So the first here we talk about, the first drug here is isoniazid, and the two types of resistances is because of mutation in genes. One is INHA, right? So this INHA, it gets or it brings about the target resistance. That means the target modification occurs here. So INH can't bind properly to the target. So it is target modification. Now, INH or isoniazid is a prodrug which needs to be activated, and the enzyme which activates is called as catalase peroxidase. Now, that catalase peroxidase is encoded by a gene which is called as CADG. CADG gene. So, if there is a modification in this particular gene, then what will happen? There will be decrease in the active form of or decrease in the activation of INH. So, the action will not occur. Number 2 is ethambutol, and in the ethambutol we have 𝗵𝗵 gene, 𝗵𝗵B gene, and again this leads to alteration in the target, altered target of the drug. Third we have rifampicin, and in this we have RPOB gene, and this is going to alter or cause alteration in the target site of RNA polymerase. So it will alters RNA polymerase. Then number 4 we have pyrazinamide. So we have PNCA gene here. Again this is going to, because again pyrazinamide needs to be activated, so this decreases the activation. It's easy to associate, INH means isoniazid, CADG you have to remember for isoniazid, 𝗵𝗵B you can make out it's for ethambutol, RPO you can make out it's for RNA, that is rifabutin or this rifampicin. Then P stands for pyrazinamide, so it is easier to associate these genes along with the drug. Now let's move on to the comparison table between these first line drugs, very, very high yield. The first is the mechanism of action. Okay, before I go on to that, I want to state or reiterate the fact that all the first line drugs, these 4 drugs, all of them are bactericidal except for ethambutol, which is bacteristatic. Remember this. Now let's move on to the mechanism of action. So the first is pyrazinamide. It gets activated and it disrupts the cell membrane. Disrupts the cell membrane. It inhibits fatty acid synthase 1, FAS1, and therefore it will weaken the cell wall. Ethambutol, it inhibits enzyme arabinosyl transferase, which is going to decrease the synthesis of arabinogalactin, which is also component in the cell wall. Rifampicin. Now, rifampicin, R for rifampicin, R for RNA polymerase. So, this is going to inhibit RNA polymerase. Isoniazid, it's a prodrug. It needs activation. So, it's activated, important point, it is activated by catalase peroxidase and it inhibits the mycolic acid synthesis. Mycolic acid synthesis. Site of action, you can, except for pyrazinamide, all the others can act both intracellularly as well as extracellularly, except for pyrazinamide, which is intracellular. So, pyrazin, zin means in, you remember, pyra is in, always intracellular, right? Pyrazin in, that is cellular, remember that always. Action, pyrazinamide, rifampicin, P and R, both, they are responsible for non-replicating bacteria or persisters, while the ethambutol and isoniazid, they act against the rapidly growing organisms of the bacteria. Excretion. Excretion, all of these drugs are excreted or they are metabolized in the liver except for the second, which is ethambutol. So, this is liver metabolism or excreted as such also, liver except ethambutol, which is renal. So, they are going to be safe in the opposite system failure. For example, liver drugs, the ones which the primary route of elimination is liver. So, they are safe in renal failures. Safe in renal failure. Safe in renal failure. While ethambutol is safe in liver failure. Opposite, right? Adverse effects, again very, very important to know the adverse effects. So, let's do the adverse effects. The first, which is pyrazinamide. First important adverse effect, it is hepatotoxic. Hepatotoxic, and it is one of the most hepatotoxic drugs out of the rest of them. So, it is the most hepatotoxic. It also leads to increase in the uric acid levels. It can cause hyperuricemia. So, therefore, it is not advised to be given in patients of gout, or you have to be very careful there, right? Then it can lead to arthralgias, joint pains. Coming to ethambutol, E for ethambutol, E for eye. So, it has a lot of eye side effects. So, it can cause retrobulbar neuritis and red green color blindness. Rifampicin. Rifampicin, again, one is hepatitis. It causes, you can say, the reddish or staining, reddish orange staining of the various secretions of the body, right? So, it stains the body secretions. So, if you don't tell the patient can get startled because of the, the urine coming orange and red. So, you have to tell the patient, stains the body secretions. So, the contact lens wearers also, they need to be given a precaution that the stains, the lens can get stained because of that, right? So, it stains the lenses. It will stain the contact lenses. So, here rifampicin, I'll write more. So, then hepatitis, staining of the secretions, it can lead to cutaneous syndrome. Cutaneous syndrome, flu-like syndrome. Remember, we cannot repeat. Once you have to stop giving the drug and you cannot repeat. In case of stop the drug and don't repeat. So why do you need to stop the drug? In case of and not repeat, this would be in case of respiratory syndrome and purpura. Okay. Then we have the last drug here is isoniazid. Now isoniazid, remember, very easy trick of its major side effects is, remember, it is INH. So N stands for neuropathy, H stands for hepatotoxicity. So these are two major problems with this drug. So the first one is peripheral neuropathy. Peripheral neuropathy, and this is mostly in case of slow acetylators. You know that INH gets metabolized by acetylation. So we have slow acetylators and fast acetylators, the one who metabolize slowly and faster. So in people who are slow acetylators, their major or their prominent side effect or adverse effect is peripheral neuropathy. And the treatment is that you give vitamin B6, pyridoxine. To prevent this, obviously, whenever we are starting anti-TB therapy, we always give prophylactically pyridoxine 10 milligrams per day. Then the second one is hepatotoxicity. Hepatotoxicity, and this is more common in case of fast acetylators. And the third one, it can cause psychosis. It decreases the levels of GABA. So these are the major adverse effects which is seen with these particular drugs. Now rifampicin, apart from being an anti-TB drug, has other important uses as well. So what are the other uses? It is a very important drug in case of leprosy. It is used for prophylaxis of contacts or prophylaxis of meningococcal meningitis. Then brucella along with doxycycline, Then it can be used in MRSA and in diphtheroids. So in all these conditions, we can use rifampicin. Another important thing to know about rifampicin is it's a very, very potent enzyme inducer. So it's a very, very potent enzyme inducer. So if you give it along with other drugs, there are bound to be various drug interactions. So important, like it can cause failure of oral contraceptive pills. If the lady who is a TB patient and is on rifampicin, and if she is either already taking or starts taking OCPs, there will be failure of contraception because it causes metabolism. So therefore, what is the treatment? That she has to be advised alternative method of contraception. Number 2 is warfarin. With warfarin, it can cause warfarin failure. Treatment, therefore, or what is the alternative? Therefore, use heparin instead. Third is failure of anti-HIV drugs. So what is the remedy or treatment? We use a drug which has less of drug interactions, like we use rifabutin instead. Okay. All right. Moving on to the second line drugs. Very, very important. Quite often asked. What are these important newer second line drugs? So one is bedaquiline. So what is the mechanism of action of this bedaquiline? So bedaquiline, see, the name says that it always lies on the bed and it is resting only, right? It has no energy. So what bedaquiline does? It blocks the mycobacterial ATP synthase. So therefore, the bacteria have no energy. They're lying on the bed. So therefore, no energy in the bacteria. Now, bedaquiline is a cidal drug. It has a very, very long half-life. So it has a long half-life of 165 days. So you give it 3 times per week because of this long half-life. Now it is hepatotoxic and it can also prolong QT interval. Because of these reasons, we don't give it beyond 6 months in any regime. The next we have delamanid and pretomanid. Now both these drugs, what they do is they are going to inhibit the mycolic acid synthesis and they produce a reactive species. Okay, so they produce a reactive species. Again, this is also a bactericidal drug and this is 99% they are plasma protein bound drugs. About the adverse effects, delamanid, it causes QT prolongation. Pretomanid with a P causes peripheral neuropathy. Okay, pretomanid with a P has peripheral neuropathy. Delamanid causes QT interval just like bedaquiline. Linezolid, it's an antimicrobial drug which inhibits the protein synthesis. So this is a drug which binds to the 23th fraction of the 50th ribosomes, inhibits the protein synthesis. Very important. Now here it has to be given for a longer period of time. So the adverse effects which we are more worried about here, that is bone marrow suppression or depression, which is reversible. But we also can have peripheral or optic neuropathy, which is irreversible. So these are the important newer second line drugs on which the question is asked. Then we have the other older drugs, other older cidal drugs. What is important to know in thiioacetazone? This we don't use in, not used in immunocompromised patients. Immunocompromised patients. Pass, it can lead to hypothyroidism. Ethionamide also causes hypothyroidism. It is also hepatotoxic and there is cross resistance with INH. So we cannot give, if there is a resistance to INH, we can't give ethionamide. And there is cross resistance with INH. Okay, hypothyroidism, PAS and ethionamide both are associated with. Ethionamide is also paratoxic and has cross resistance with INH. Cycloserine can cause psychosis and suicidal thoughts. Okay. Now, we have grouping of the anti-TB drugs in group A, B and C, and this is actually group when we were designing the longer MDR tuberculosis regimes. So we have to include all the 3 medicines from group A, at least 1 or 2 from group B, and let's say from group A and group B we are not able to use 1 or 2 medications because of some contraindication, then we add, to supplement those, we add drugs from group C. So in group A, levofloxacin, bedaquiline, linezolid. Group B, clofazimine, cycloserine or trazodone. And in group C, we have the other drugs like ethambutol, delamanid, pyrazinamide, imipenem, meropenem, amikacin, ethionamide, etc. and pass. Right? So remember, that's why this grouping has been done. So when they say you add group drugs from group 1 especially, so we mean we add these 3 drugs from group A. So let's see the various treatment regimes, which is important. Now, in case of MDR tuberculosis, multi-drug resistant tuberculosis, what is important to know is that we have now a shorter regimes, which are because of bedaquiline, shorter regimes. So here the intensive phase is of 0 to for 4 months. No, intensive is of 6 months, but for first 0 to 4 months, we are using a total of 7 drugs. Bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose isoniazid and ethionamide. So what do you mean by high dose isoniazid? We are using 15 milligrams per kg per day. That's a high dose. Then for the next 2 months, what you have to do, you simply remove the last 2 drugs. So you remove INH and ethionamide, and we have the 5 drugs now. So we have bedaquiline, we have levofloxacin, we have clofazimine, we have pyrazinamide, and we have ethambutol. So these are 5 drugs now. Now I told you bedaquiline cannot be given beyond 6 months. So when we move on to the continuation phase, which is from 7 to 9 months, you just remove bedaquiline from here. So remove bedaquiline and continue with 4 drugs. So this is a shortened regime because of addition of bedaquiline. That's why it has come into picture that because of bedaquiline, the regime could be shortened for multi-drug resistant tuberculosis. Now for pre-drug, pre-XDR or pre-extensive drug resistant tuberculosis. So what is pre-extensive drug resistant tuberculosis? If there is MDR plus in addition there is resistance to any of the fluoroquine. So what to be done here is we have a 𝗵𝗃 regime. So we have a 𝗵𝗃 regime, and this is for 6 to 9 months. Again, it's all oral. So here we have bedaquiline, we have predominant, and we have linezolid. Right? Predominant, linezolid and bedaquiline. Now there is also another regime. So if those MDR patients, the ones which could not be taken up or who could not be given the short 𝗵𝗃, this regime, so exclusion to this MDR. So either we have XDR or exclusion cases of MDR who could be given the prior this regime. They now need to be given drugs for about 18 to 20 months. So here we have the long regime, the longer oral regime. So here I was talking about that we need to include groups from A, B and C. So here what you do is for 0 to 6 months, we have the regime of around 5 drugs. 5 drugs. So 3 from group A plus 2 from group B. Then 7 to 18 months. So for 7 to, we cannot use bedaquiline. So for 7 to 18 months, we use 4 drugs. we use levofloxacin, we use linezolid, we use clofazimine, and we use cycloserine. So apart from bedaquiline, we use the other drugs. Now, in case let's say some patient has or has contraindication to any one or two drugs, then we take drugs from group C. Otherwise, we mainly rely on group A and B. So this is the importance of knowing about group A, group B, and group C drugs. All right. Now let's see a question which was asked in one of the previous year's paper. Which of the following is an inclusion criteria for the shorter bedaquiline regime in the treatment of tuberculosis? Number 1, extrapulmonary tuberculosis like tubercular meningitis, rifampicin resistance with both 𝗏𝗏𝗃 and INH mutation, rifampicin sensitive tuberculosis, or rifampicin resistant but chloroquine sensitive tuberculosis. So what should be the exclusion criteria for this? So let's see the exclusion criteria and the inclusion criteria for short bedaquiline regimes. So the indications for inclusion criteria is number 1, it should be a rifampicin resistant or an MDR-TB. Number 2, it should be resistant to sensitive to the fluoroquinone. It should be sensitive to the fluoroquinolones. Then it should only be pulmonary tuberculosis. Then we have the age of the patient should be greater than equal to 5 years. Then it should be, the patient should be clinically stable. Then no prior use of any second line drug should be there. So this is all the inclusion criteria. What is the exclusion criteria? You cannot give this short bedaquiline regime if there is resistance to fluoroquinolones. If it is an extrapulmonary tuberculosis, so there is extrapulmonary tuberculosis. For example, it is TB meningitis, right? Or TB is in the bone. Then you cannot give this. Then the third, if there is QT prolongation, because bedaquiline also causes QT prolongation, and if patient already has this QT prolongation, you can't give this. So the question for us here was, which of the then is an inclusion criteria? So extrapulmonary, this becomes an exclusion criteria, not an inclusion. Rifampicin resistant with 𝗏𝗏𝗃 and INH. So 𝗏𝗏𝗃 and INH, this is not rifampicin, this is INH resistance. Rifampicin sensitive tuberculosis, no, we need a rifampicin resistant TB. And the last one is rifampicin resistant but fluoroquinolone sensitive. Yes, we need a TB which is still sensitive to fluoroquinolone. So this is the correct answer. All right. Next we have, in special situations like let's say there is tuberculosis along with HIV. Now what to do? So if there is a patient on HIV and of HIV who develops tuberculosis, what should you treat first? So first you should treat the tuberculosis. So start anti-TB therapy first. And after 2 weeks you give antiretroviral therapy. This is so because if you give antiretroviral therapy beforehand, because the immune system of the patient is going to improve, they are going to target the mycobacteria. There's going to be an immune reaction, and this is called as, there is going to be risk of IRIS, which is called as immune reconstitution inflammatory syndrome. So because of this problem, the immune system action against the mycobacteria, so therefore you need to treat the TB first and then you follow up with ART. Also another thing that you should know in this, you replace, to take care of the drug interactions, replace rifampicin with rifabutin. What about pregnancy? You can give all these drugs, so just avoid giving aminoglycosides. Right? Only aminoglycosides cannot be. They are contraindicated in case of pregnancy. Alright. Now, moving on to the next disease, which is leprosy. So, what are the important drugs for leprosy? Now, leprosy we treat if it is multibacillary or it is paucibacillary, depending. So, how can we make out if it's multibacillary or paucibacillary? By looking at the lesions and the other features. So, if there are 6 or more lesions, it is multibacillary and more than one nerve involvement is there. While in paucibacillary, the lesions are 1 to 5, skin smear is negative and there may be no nerve involved or only one involved. Now, the treatment protocol is the same for both of them. The only difference is in the duration of the treatment. So, now the duration of multibacillary, obviously it is longer, and for paucibacillary it is shorter, that is about 6 months. Otherwise, it is the same. The drugs are same. The way in which it is given is also the same. Now, let's see that. So, in children also, in 10 to 14 years, the dosage is different. So, we'll do that as well. So, rifampicin, we use 3 drugs: rifampicin, dapsone, clofazimine. Now, out of this, rifampicin is the only cidal drug. The rest 2 are static drugs, right? And clofazimine is also an anti-inflammatory. So, you give rifampicin 600 milligrams once a month. Here also 600 milligrams once a month. Both. So, obviously, if it is just once a month, it can be supervised. So, these are both supervised. Dapsone has to be taken 100 milligrams daily. 100 milligrams daily. So, obviously, every day nobody can supervise. So, this is unsupervised. Coming to clofazimine. So, how to remember for clofazimine? Now, do half of 100, it is 50. So, the patient has to take 50 milligrams daily. Daily dose of dapsone is 100. So, half it is 50 milligrams daily for about 29 days. 29 days. Same here, 50 milligrams daily for 29 days. Unsupervised, daily is never supervised, plus or and once he has to take half of 600, that is 300. So, 300 milligrams once on 30th day, you can say. So, 300 milligrams once on 30th day. So, obviously, once, whatever is once in a month, that can be supervised. So, clofazimine, easy to remember. Half of 100, the half of the daily dose is now 50, which is to be given daily, and the one dose which has to be given on one day should be the half of the dose that was given previously for one day. So, 600 half is half, 300. So, here it is given 300, here it is 50. Now, let's go to the children, doses in children, how to remember that. So, first we'll go and see for dapsone. So, dapsone, the dose is half here, right? So, here we have 50 milligrams, right? Half of the dose. Now, for clofazimine, it is again same, 50 milligrams on alternate days. That's the difference, on alternate days. Plus, add 100 to 50, it becomes 150. 150 milligrams. So, one day has to have 150 milligrams. Now what you do? You do add here. This is 150 and here you have, how you remembered it, 100 plus 50 is 150. Now go to the rifampicin now. So rifampicin dose is now how much? 450. Rifampicin dose is now 450. Okay. So this is the difference in the children's dose. Here first we are doing this 50 and then we are doing 50 plus 150. So half of dapsone, 100 was the adult dose, 50 is the half the dose, and we come to clofazimine to give 50 but on alternate days, and you do half of 300. You can do that is 150 or add 100 to 50, it's 150, any way which you want to remember. So this becomes your 150 and you can add here 450 of the rifampicin. So this is the only difference in the dosing of children versus the adults. Now other drugs which are used in leprosy, which we already done, apart from dapsone, clofazimine and rifampicin, we have ethionamide also, which is also an anti-TB drug, and then we have certain antibiotics. We have fluoroquinolones, we have macrolides, and we have minocycline. So fluoroquinolone, macrolides are both cidal drugs here, and then we have minocycline. Okay. Now dapsone, important thing, inhibits the fatty acids, folic acid synthesis here. So dapsone inhibits the folic acid synthesis, very important. And the adverse effect, important, is it causes hemolysis in G6PD deficient patient. It can cause nausea, vomiting and sulfone syndrome. Other uses, it is also used in chloroquine resistant falciparum malaria and pneumocystis 𝗷𝗫𝗂𝗏. Other uses of dapsone. Then let's do some important points here. The most potent or the most effective drug for leprosy is rifampicin. Right? The main adverse effect of clofazimine. Now clofazimine is the dye. What is the main adverse effect of clofazimine? It is reddish black discoloration of the skin and this is called as 𝗙𝗵𝗄𝗧. It looks like a fish-like skin, right? 𝗙𝗵𝗄𝗧. What to do in case of single lesion leprosy? You remember the mnemonic ROM. Give these three drugs that we have: rifampicin, ofloxacin and minocycline. Lepra reaction, ENL. Do not, in case this occurs, do not stop the multi-drug therapy. So do not stop the multi-drug therapy. You give steroids here. Give prednisolone first to stop this reaction. If it is still persisting, if still persists, then you give other anti-inflammatories like thalidomide, or you can give clofazimine. Okay, but remember, thalidomide is absolutely contraindicated in case of pregnancy, right? Because it had association with phocomelia. So these are the important points about antitubercular and anti-leprosy drugs. So here today we are going to talk about the antiprotozoal drugs. So let's see the first antiprotozoal drug group, in which we have the anti-malarial drugs. So which of the anti-malarial drugs where I have the fastest action, or which are the fastest acting schizonticides. So they target the RBCs there. So parasites in the RBCs. So we have here the artemisinins. Artemisinins. And out of this, artesunate, that is the fastest. Now, the only problem with this group of drugs is that they're very short acting drugs. So, because of this, there is a higher rate of recrudescence. So, they are short acting, therefore fast recrudescence. Hence, we need to combine it with the other long acting drugs. Therefore, we go for the artemisinin combination therapy. We never give them alone. Now, moving on to the different treatment regimes for chloroquine sensitive vivax or chloroquine sensitive ovale. Remember, falciparum, we consider it as resistant to chloroquine. So, we are going to do chloroquine sensitive vivax or ovale. So, obviously, if it is chloroquine sensitive, that means you have to give chloroquine. So, what to do? The treatment, the clinical cure for the clinical cure here. Clinical cure. So, clinical cure, we give chloroquine 600 milligrams, stat. This is on day 1. Then after 8 hours, you have to give another 300 milligrams. Okay. Then day 2 and day 3, 300 milligram per day on both the days. So basically what we want to do is you want to give a total dose of 25 milligrams per kg. So for a 60 kg man, roughly it comes out to be around 1500 milligrams. So that's what you want to do. Now remember why we're giving 600 milligrams stat and another 300 milligrams later. So we are initially giving a loading dose of chloroquine. Why are we giving a loading dose of chloroquine? Remember that chloroquine has a very, very high volume of distribution. So it gets distributed to the liver and the eye. But we want the action in the blood, in the RBCs. So that what we do, we give a loading dose so that it can actually first go saturate those sites and then it comes into the blood. Only then it can come into the blood and produce their effect. So therefore, the concept of loading dose here is because it has a very high volume of distribution. Alright, so this was about the clinical cure. Okay. Now, it's not sufficient just to do the clinical cure, because for the complete cure in case of vivax and ovale, we also need to target the, the parasite which is lying inside the liver. They're sleeping inside the liver, or that's called the hypnozoid state. So remember, this is the liver if here. Okay, let's make the liver here. So we have in the RBCs also, right? So we have the parasites and the RBCs that get taken care by the schizonticides. But in the liver, in the cells, in the liver hepatocytes, there are some dormant parasites. So they are called as hypnozoids. Now, if you don't treat these, what will happen? They will wake up, and again they will attack the RBCs, and patient will have a relapse of malaria. So for a complete cure, you have to target not only the parasites in the RBCs, but you also have to target the hypnozoid. So clinical cure, that means in the RBCs, that is done by the chloroquine. But what about the hypnozoid stage? We need another drug for this. So drug effective, and this is called as the radical cure. So radical cure is when you completely take care of this infection. So radical cure, for radical cure, what you do, you would give primaquine. So you can give primaquine 15 milligrams per day, and you need to give it for 14 days. Or we have tefinaquine. You can give single dose of tefinaquine. That is also possible. So either you give primaquine or you give tefinaquine single dose. So both of them, they are going to target the hypnozoid stage and they bring about the radical cure. So remember, this is only for Vivax and Oval. For Falciparum, we don't have any hypnozoid stage. There you would not need to give it for such a long period of time for this purpose. Okay. So important here, clinical cure and radical cure. Now what is the other thing that we need to know here? For chloroquine, you need to know certain side effects. So it can cause a typical in the eye. It can cause bullseye retinopathy. Though this is more common if you use chloroquine for a prolonged period of time. So here you're not using it for a prolonged period of time. But let's say in cases of rheumatoid arthritis where you're using for a long time, there this problem is more evident. But yes, you need to know what are the issues. This bullseye retinopathy is because of chloroquine. It looks like a bullseye. Secondly, there is a tendency to cause QT prolongation. And number 3, primaquine has a maximum tendency to cause hemolysis in G6PD deficient individuals. So primaquine causes G6PD. In G6PD deficient patients, it can cause hemolysis. So primaquine especially has a maximum tendency to cause this. So these are few things that you need to know. Moving on to the chloroquine resistant Vivax or falciparum malaria or mixed Vivax falciparum, which you also treat like chloroquine resistant malaria. So what here obviously if it is a chloroquine resistant case, chloroquine is out of question. So what is the choice? Next we have the ACT, artemisinin combination therapy. That is the treatment of choice. So ACT we are going to give. Now, how and what are we going to give here? So we are giving a combination of artesunate 50 milligrams. So 4 tabs of this. This is given for period of 3 days. Plus you give sulfadoxine and pyrimethamine combination. This is given on day 1. How much are we giving? 2 tabs, 750 and 37.5. Then we also have to give primaquine. We have to give single dose of primaquine, 2.5 milligrams, 6 tabs on day 2. Now here the role is not for radical cure. It is not given because there is no hypnozoid phase. Here the role is only that this acts as a gametocidal. Now this is the regime which is practiced in most parts of India except for the northeastern states, because in the northeastern states sulfadoxine pyrimethamine resistance is there. So this is not for northeastern states. So what will we do in case of northeastern states? We are still going to give ACT but a different combination. So here we give artemether plus lumefantrine for 3 days. Now lumefantrine is a drug whose absorption is increased if we give it along with a fatty meal. So you can give this with fatty meal to increase the absorption. Okay, so remember this, that in the chloroquine resistant Vivax, falciparum malaria, mixed infections, you treat it as a resistant only, and we have the artemisinin combination therapy. So for all the parts of India except for northeastern states, this regime is followed, and this doesn't need the primaquine effect for the radical cure. Its radical cure is only with the ACT as such, and gametocidal action because of the primaquine. And for the northeastern states, we have a different combination of ACT. All right. Moving to the severe malaria. If there is severe complicated cerebral malaria, what to do? So this is an emergency, like, so here we are going to give intravenous artesunate. So we give intravenous artesunate. But in people who might have some allergic reactions to this artesunate, who are not tolerating this, we can also give quinine. Right? So the other alternative is quinine. Remember, for quinine, you give it in 5% dextrose. So give it, right? So give it with 5% dextrose to avoid hypoglycemia, because it causes hypoglycemia, to avoid hypoglycemia, right? So with 5% dextrose. All right, another important thing, what happens if there is a pregnant female who gets malaria? So malaria in pregnancy, what to do? If it is, see, the best treatment of choice, the best drug of choice in pregnancy, the safest is chloroquine. So if it's a chloroquine sensitive malaria, Vivax, uncomplicated, you will definitely go with chloroquine. But remember, primaquine cannot be given. So you have to give only chloroquine, no primaquine. Why? Because primaquine causes hemolysis in G6PD deficient individuals, and the fetus is G6PD deficient. So there will be hemolysis in the fetus. Therefore, absolutely contraindicated. Now, for falciparum, which is resistant to chloroquine, what to do? Otherwise you would have given ACT. But the problem with artemisinin drugs is that they are teratogenic. So in the first trimester, we give quinine plus clindamycin. And in the second and third trimester, we can then begin with the ACT regimen. Okay. Severe complicated cerebral malaria in a pregnant female. Now, otherwise, our drug of choice is IV artesunate. What to do in this case? Here, if the mother is having complicated malaria, severe cerebral malaria, so we cannot compromise on her health. So here our mother becomes the priority and we have to save the mother. So rather than the baby, we prefer to save the mother. So here, regardless of the trimester, we will give IV artesunate. So in all trimesters. That's the guideline. All right. Now, to the other end, we move that if there is a traveler who is going to a place which is endemic for malaria, so what to do there? So for them, we need suppressive prophylaxis. Let's say it depends on what or how much time that person is going to stay there. If the stay is a longer stay, more than 6 weeks, so what to do? Then your drug becomes mefloquine, 250 milligrams once a week. Longer stay, so only once a week he needs to take a tablet. It's good for compliance also. So what and how to start? So start 2 weeks before travel. 2 weeks before travel and continue 4 weeks after coming back. Okay. Now, mefloquine has one drawback, or the ADR, that it can cause neuropsychiatric reaction. So the ADR is neuropsychiatric reactions. Therefore, it is contraindicated in cerebral malaria and even in psychosis. We can't give them. Then QT prolongation, though it has least tendency to cause QT prolongation, but we can't combine it with. So for Q, don't combine with quinine or halofentrin, because they all cause QT prolongation, right? And because of this, we need to avoid with other drugs which also causing the QT prolongation. Now, if the stay is for less than 6 weeks, shorter stay, then you can just give doxycycline, and that you need to give every day, 100 milligrams every day. So this needs to be started 2 days before travel. 2 days before travel, and same continue 4 weeks after coming back. Now, doxycycline, remember, it's a tetracycline group, so we cannot give it in cases of pregnancy, or we cannot give it in children. So it is contraindicated in pregnancy or children. Then you can give mefloquine. So here, this you have to keep these things in mind. Now moving on to the other protozoal infections. So the first one after malaria is amoebiasis. So what is the drug of choice for intestinal amoebiasis, amoebic dysentery, or amoebic liver abscess? So these ulcers or amoebic ulcer which is formed by this, they are usually also called as flask-shaped ulcers. So this kind of ulcer they form. Flask-shaped ulcers. So the drug of choice here we have is metronidazole. What are the other uses of metronidazole? Number one, it is used for anaerobic infections. Anaerobic infections, but below the diaphragm. Below the diaphragm. So above the diaphragm we have C, below the diaphragm we have M. Clindamycin above the diaphragm, and below the diaphragm we have M. Then it is also used in case of giardiasis, trichomoniasis, number 4, it is used in bacterial vaginosis. It is used in H. pylori. Then in cases of trench mouth, gingival hyperplasia, etc. Another important thing to know that this drug can cause disulfiram-like reaction with alcohol. So if a patient is on metronidazole, the patient is instructed not to consume alcohol during the treatment with metronidazole, and even 3 days after stopping the treatment with metronidazole. Moving on to the next, we have in case it is asymptomatic and there is just luminal amoebiasis, right? So that means, so this is the intestine. Let's say this is the intestine. So the cysts, they are just in the lumen. They're not causing any symptoms. They're not invading the mucosa. So what to do here for luminal amoebiasis? The drug we have is oral paramomycin. So it's an aminoglycoside given orally because we want the local action in the intestine itself. So it is oral paramomycin. Now, moving to leishmaniasis, visceral leishmaniasis, which is also called as 𝗪𝗏. What is the drug of choice for us? The drug of choice for us here is intravenous liposomal amphotericin B. Now, amphotericin B is a very nephrotoxic drug, lot of side effects. And what happens is, if you give it in liposomal formulation, it's a targeted delivery, there are less side effects with liposomal amphotericin B. So it's a drug of choice, but it's a expensive drug, right? So what does amphotericin B do? That in the cell wall, it will create holes. It combines with the ergosterol and it forms holes, and the important amino acids, etc., from the protozoa will leak out and cause the death of the protozoa. So, drug of choice is IV liposomal amphotericin B. The oral drug of choice, if you oral, is miltefosine. So, only oral drug available. Now, drug of choice for post-𝗘𝗏𝗄𝗏 dermal leishmaniasis is again oral, miltefosine. Okay. Now, moving on to the drug of choice for cutaneous leishmaniasis, which is your oriental sore. Here we use sodium 𝗕𝗏𝗡𝗏. Drug of choice for African trypanosomiasis. So, we have recently, the treatment has evolved from the parenteral to the oral therapy, which is oral 𝗥𝗡𝗄𝗎. And for American trypanosomiasis, we have benznidazole. Drug of choice for toxoplasmosis, we have sulfadiazine plus pyrimethamine. But remember, if in pregnancy we don't use this drug. We use 𝗲𝗏𝗏𝗏. So, these are the various drugs for the protozoal infections. Today, we are going to discuss about the non-retroviral and antiretroviral drugs. So, let's get started. Now, first in the non-retroviral drugs. So, what are the important points to know for us? So, which are the drugs which are used for treatment of various herpes infections? So, for herpes simplex virus and varicella zoster, herpes zoster virus, our drug of choice is oral 𝗙𝗙𝗏𝗡𝗏𝗏𝗡. So, we prefer this to 𝗙𝗙𝗏𝗏𝗡. So, 𝗙𝗙𝗙𝗏𝗏𝗡. Then, drug of choice for HSV encephalitis. So, this is indication for IV 𝗙𝗙𝗏𝗏𝗡. Remember, 𝗙𝗙𝗏𝗏𝗡 has an important side effect that you should know, that it is a nephrotoxic drug. Nephrotoxic drug. Now, 𝗙𝗙𝗏𝗏𝗡 needs activation in two steps. One in the virus and second in the host. So, we have virus kinases and then we have the host kinases, which ultimately activate it to the triphosphate form. That's the ultimate active form. So, 𝗙𝗙𝗏𝗏𝗡 needs activation. Now, resistance to this drug or these drugs occur when there is mutation in this particular step. The viruses, they will mutate and they will not allow the drug to actually get converted into the monophosphate. So, there in those cases, these particular drugs will not be effective. So, for this, we have some other drugs like cidofovir, 𝗕𝗏𝗏𝗏, trifluridine, which will bypass that step. So, these drugs, you see this step, they do not require any virus enzyme activation. So, they bypass this virus step. So, they can be given in case of acyclovir resistant herpes. So, cidofovir and 𝗕𝗏𝗏𝗏𝗏. What else should you know about cidofovir? That it's a myelotoxic drug. Myelotoxic drug. And 𝗕𝗏𝗏𝗏𝗏 can also cause electrolyte imbalance. So, these are the two important things that you should be knowing about this particular drug. Moving on to the drugs for CMV, cytomegalovirus infection. Now, oral 𝗙𝗙𝗪�cyclovir. This is a drug of choice for CMV retinitis. While if we talk about IV ganciclovir, this can be used in case of CMV pneumonia. So this is preferred for CMV pneumonia. Ganciclovir, remember the important adverse effect, which is bone marrow depression. So we have to take that into account. Then we have some newer drugs also for this. We have letermovir and maribavir. So remember that. We always understand that it is to do something with the viral infection. Then influenza, drugs for influenza. So it is influenza A, B and bird flu. So we have drugs for these infections. Now the first group or the first drug which we have amantadine and rimantadine, they are only active against influenza A, not against B and the other. And what is their mechanism of action? They inhibit or block the M2 proton ion channel. This M2 proton ion channel, if it is blocked, there will be no uncoating of the virus. The virus needs to get uncoated. So there is a coating in the virus, right? And uncoating is required. That means this needs to go away. Now this uncoating, for it to go away, this is an important channel, M2 protein ion channel. If this is inhibited, then there is going to be no uncoating of the virus. It will not be able to replicate. So that is the mechanism of action of this drug. But we don't use this currently. So rarely used now. You remember amantadine is an anti-influenza drug, but it is used in case of Parkinsonism also. So it is not much used now. Coming to the most important out of this in the anti-influenza drugs, we have oseltamivir, zanamivir and peramivir. Now, oseltamivir, O for oseltamivir, an oral drug, this is one. And zanamivir is usually given, it is inhalational form and given in case of oseltamivir resistant cases. Then peramivir can be given in single dose and it is given as IV formulation. Now, they are effective against all types of influenza, right? So, influenza A, B and also the bird flu. Remember, Tamiflu was a drug, so that is given. Important thing, what is the mechanism of action? Mechanism of action that these are neuraminidase inhibitor. Therefore, the virus can't be released. Can't be released. So let's say this is a structure, the cell where the virus is, growing inside and it is, replicating inside the cell. Now, to spread to the other cell, it needs to be released from here. So what happens here? There is neuraminidase which is present here and this needs to attach to the host cell membrane and ultimately the virus will be released, right? So the virus will be released, right? But this step is prevented by oseltamivir and the like drugs. Therefore, it will not allow the release of the virus. So the infection is not going to spread. That is the major mechanism. Now, treatment. Whenever we are using it for treatment, we use it for a period of 5 days. Prophylaxis, 2 extra days, right? There's a newer drug which is 𝗲𝗏𝗃, and this is given as a single dose oral treatment, right? Single dose oral treatment is given with this drug, and this inhibits the initiation of mRNA synthesis, right? So this inhibits the initiation of the mRNA synthesis. It has a different mechanism than the others. So 3 groups here we have in the influenza. One is targeting the M2 protein ion channel, that is amantadine. The second are the neuraminidase inhibitors, and the third one inhibit the initiation only of the mRNA synthesis. Then drugs for hepatitis B. Now, anti-hepatitis B virus, the first line drug is we have tenofovir and entecavir. These are the two first line drugs. Tenofovir is contraindicated in children less than 10 years, and they are safe in liver disease, right? But not safe in renal disease. Now, tenofovir, if you're given for a long term, it has a problem of causing bone marrow depression. So that's why we are apart in children as well. Other drugs which can be given with this drug, they're not the first line, but the other drugs can be given is lamivudine, adifovir, and we have interferon alpha. And interferon alpha given for 48 weeks. Now, very important, interesting question is, which are the three drugs which can be used both in HPV infection as well as the HIV infection? So, the mnemonic is LET drugs. So, L stands for lamivudine, E stands for emtricitabine, and T stands for tenofovir. So these three drugs can be used for both managing the HPV as well as the HIV infection. Coming to the anti-hepatitis C virus drugs. Now, initially we had few drugs like ribavirin, interferons, they are toxic also, not the way direct acting. But now the treatment has been revolutionized with the availability of the directly acting drugs on the virus itself. So what are these drugs? That is very, very important. So we have drugs like 𝗕𝗵Previr and paritaprevir. So what is the role of these drugs? So previrs, these are protease inhibitors. So what are these? These are protease inhibitors. And what is the role of protease enzymes basically? The protease is responsible for cleaving of the polyproteins into smaller proteins. So protease inhibitors, the protease as such, they cleave the polyproteins into smaller proteins, right? So this will get now inhibited. So there is inhibition of these because otherwise polyproteins are of no use to the virus. They need small meaningful proteins for them. So that is not there now. So the target for the action is NS3/4. So this is the target now. The second target is they are going to target NS5B, right? They target NS5B, and the drugs are sofosbuvir and dasabuvir. So here, how can you remember? They have buvir, B-U-V-I-R, B-U-V-I-R. So B, remember, they are going to target the NS5B. And when they target this NS5B, they inhibit the viral RNA polymerase. Then we have the other drugs, daclatasvir and 𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪𝗪 So they are going to target NS5A. So A they are going to target. Okay. So BOVI targets NS5B and ASFI targets NS5A. That is important. This is how you can remember this. So they inhibit viral replication, and assembly, both. Viral replication and assembly, both. Then these were the directly acting drugs. Then we have other drugs like ribavirin. Again, it has a virus. It means again it is virus, VIR in them. Virin, that is they inhibit the viral RNA synthesis. RNA, so the VIR RNA synthesis, inhibit the viral RNA synthesis, right? That is the important thing to know here. So they or this drug is used orally in chronic hepatitis C infection along with pegylated interferon alpha. Important is that it's used along with pegylated interferon alpha. So interferon alpha here, we use it for a long period of time, 6 to 12 months. What is the other use of ribavirin? So ribavirin also used in RSV treatment. Respiratory syncytial virus treatment, also used in RSV treatment. For prophylaxis of RSV, we use palivizumab. Remember these important drugs which are asked. So for RSV treatment, we are using ribavirin, while for prophylaxis, we use palivizumab. ADRs of ribavirin, it can cause hemolytic anemia, and bone marrow depression. Even interferons can cause bone marrow depression. So these are the important points about drugs acting against hepatitis C virus. Now moving on to the next, we have the antiretroviral drugs, right? So initially we have done the non-retroviral, now the antiretroviral drugs. Now we have various drugs which can be groups classification. So remember what happens in retroviruses is that this is a retrovirus. It has GP120, it has GP41. Now GP120, the role is to cause attachment to the host cell. So for the attachment to the host cell, this is causing the attachment to the host cell. And on the host cells, we have CCR2, CCR5, and CXCR4, right? We have these. And we have CD4 also on the host cell. So they are helping in the attachment, and and ultimately the fusion occurs by GP41. This is important for the fusion to the host cell. So first attachment and then the fusion, and then what happens, this virus which contains the RNA, it will enter inside. So once the fusion is there, then this will enter inside the host cell. There is an enzyme it is present actually along with the virus only. So this is the enzyme here, which is called as, reverse transcriptase enzyme. What is the role of reverse transcriptase enzyme, and why the name? Because normally what happens if we form RNA from the DNA? So normally RNA is formed from DNA, but in this case, the reverse is happening. From the viral RNA, we are forming the viral DNA, double-stranded, right? So this is happening in the host cells. So when this happens, the enzyme reverse transcriptase is important. After that, what is happening is it goes inside the nucleus. Already in the host nucleus, there is DNA. So let's say we have a DNA here in the host nucleus. This viral DNA is going to get integrated into the host DNA. So here you see this is a host one, and here the viral DNA also gets integrated, and now it becomes a part of the host DNA. So this responsibility is with integrase. So it is integrating the viral DNA into the host DNA. This is integrase. So then there is replication, then there is formation of mRNA, right? The protein synthesis occurs, replication is occurring here. So when the proteins are formed, so this is all yet the cell only. Now then the proteins are formed. So when the are formed, again these are polyproteins being formed, right? So let's say there are so many from here, the synthesis, polyproteins are being formed. They need to be now broken down into simpler proteins, smaller proteins. And for that, we require protease. So then smaller proteins are formed and other viral components, they come together, and there is another. Now these viruses, they are formed and then they're going to be released. So your antiretroviral drugs, they are going to target these different steps. So for example, the first step that we have is for entry inhibitors, right? So the entry inhibitors, either they target the GP120 or 41, or they block this so that the entry of the virus can be blocked. Second step is you block this reverse transcriptase. So we have reverse transcriptase drugs. So nucleoside and non-nucleoside and nucleotide reverse transcriptase inhibitors, right? Then we have integrase inhibitors, which are going to prevent the integration. Then we have the protease inhibitor. So all our drugs are going to target these particular steps. So with this background information, let's now move on to the drugs. So first we're going to do the entry inhibitors. Remember, the first step is GP120. So to block this first step, we have a drug fostemsavir. Okay. So remember, it has FOST. FOST means first. So the first step that is blocked is the attachment. So GP120 is responsible for attachment. So fostemsavir is going to block this attachment. The drawback with fostemsavir is that it can cause QT prolongation. QT prolongation. Next step is fusion. So GP41, it is responsible for fusion. So 40 starts with 4. Fusion starts with F. 40 means F. F. Fusion also has this. So fusion inhibitor. So F, F, and the name also has few. The name is N4V-diet. Okay. So remember F of 41, few of fusion, and few of 4V-diet. N4V-diet. So that is a step number 2. Then we have drugs binding to CCR5 or binding to both CCR2 and CCR5. So CCR, you remember that R, just remember rock. So these are rocks. So we have a smaller rock and we have a bigger rock. So if only one CCR2 is blocked, we require a smaller rock over there to block it. But if 2 of CCRs have to be blocked, we require a bigger rock. So we have 2 drugs. The one with the smaller spelling is going to block the CCR5. And that drug is Mara-Vi-Rock. So they are rocks which are going to block this CCR. So also there's another way to remember this. Mara-Vi-Rock. Y is viral and V stands for 5 in Roman numbers. This is 5. And so this is only again CCR5. The ones or the drug which blocks both of them. So that has a longer name. So what is that name? Let's do. It is 𝗕𝗵𝗏, right? 𝗪𝗙𝗔𝗏, and it is going to block both CCR2 and CCR5. And see how many C's are there? 2 here, 2 here, 4 C's. So this also has 1, 2, 3, 4, 4 C's. So that's another way of remembering. But you can remember the one with the bigger spelling, that's the rock with the bigger spelling is blocking both these, and one with the smaller one, Maraviroc, is blocking only CCR5. Then we have another drug which is going to be, it's a monoclonal antibody, and it is not only against the CD4. So it is not targeted only against CD4, but also CCR2 and CCR5. So that drug is called as 𝗖𝗵𝗎𝗍𝗪. It's the only monoclonal antibody of the blood. So in Bali, right? So we have, you stay for 4 days, CD4. Stay for 4 days in Bali. Okay, remember that way, CD4, 𝗖𝗵𝗎𝗍𝗪. Then we have a capsid inhibitor. So capsid protein they block, and the name is 𝗙𝗵𝗃𝗂𝗏. So it has cap in the spelling only. 𝗙𝗵𝗃𝗂𝗏. So they are going to inhibit the capsid. So that is the first step. Now, second is to block or inhibit the reverse transcriptase. So we have reverse transcriptase inhibitors now with us. So we have first nucleoside reverse transcriptase inhibitors. Remember, a mnemonic here for these drugs is Lisa did stay. So L is lamivudine, E is emtricitabine, Z is zalcitabine, then we have zidovudine, and then we have A is abacavir. Did means didanosine and stay means stavudine. So these are your nucleoside reverse transcriptase inhibitors. So which of them is the best or are the best tolerated NRTIs? Here we have drugs like lamivudine and emtricitabine. Remember, emtricitabine has one issue or one problem, adverse effect of causing the hyperpigmentation of the palm. So if the question is an image-based question, which of the antiretroviral drugs is associated with hyperpigmentation of the palms and soles, it is emtricitabine. Most common side effect of NRTIs are the rashes. So it's the rash. Major side effect of zidovudine. It's one of the oldest drugs. And what is the major drawback with zidovudine is myelosuppression, bone marrow depression. So that is myelosuppression. So therefore, it is contraindicated if the HB of the person is less than 9. Then we will not like to give this drugs. Also, it can cause myopathy and it can cause hepatotoxicity. Okay. Dose limiting side effect of didanosine, that is pancreatitis, right? So pancreatitis is the dose limiting toxicity, but didanosine can also cause peripheral neuropathy, right? Apart from this, it can also cause peripheral neuropathy, but this is a dose limiting side effect. Major side effect with stavudine, again, it can cause peripheral neuropathy and lipodystrophy syndrome. Side effect with abacavir, it can cause hypersensitivity reactions. Then, which of these drugs should not be combined together when you give? So, do not combine zidovudine with stavudine. Why? because they can antagonize each other. So pharmacodynamic antagonism, so they can antagonize each other's effect. Also, if you give 𝗲𝗔𝗃𝗡 with didanosane and with stavudine, there is increase in the risk of peripheral neuropathy. So these combinations you should be avoiding. Then we have nucleotide reverse transcriptase inhibitors like tenofovir. So in the tenofovir, important is that it is a very nephrotoxic drug. And it is not used in children less than 10 years or if the weight is less than 30 kg because we don't have sufficient data to prove its safety in these people. All right. So there was one MCQ in the previous years. Which drug binds to CD4 as well and has activity on both CCR5 and CXCR4 in the tropic HIV infections? So CD4, where you see it is Bali. Bali has 4 days. So this is 𝗲𝗏𝗡𝗵. Okay. Now here, Maraviroc is only active against CCR. We said 5. 𝗙𝗵𝗃𝗏𝗏, wherever you see gravir, it is an integrase inhibitor. So these are integrase inhibitors. Then navids are protease inhibitors. Remember this way. Then we have NNRTIs. Here we have nevirapine. So important thing to know about nevirapine, it is the drug of choice for prevention of vertical transmission in HIV, right? So from the mother to baby prevent. Efavirenz, remember it has a one major drawback, which is psychosis. Now this is a newer drug which has a slightly different mechanism, that it is a nucleoside analog reverse transcriptase translocation inhibitor, right? Nucleoside analog reverse transcriptase translocation inhibitor. Then we have integrase inhibitors. So integrase inhibitors, I told you they are called as gravirs. So we have dolutegravir, we have 𝗙𝗵𝗃𝗏𝗏, we have raltegravir, and we have long-acting 𝗕𝗵𝗃𝗏𝗏. So to boost the effect of 𝗙𝗵𝗃𝗏𝗏, can we give some drug? Yes, we can give a drug called as 𝗘𝗵𝗄. How it boosts? Because it is a inhibitor of an enzyme cytochrome P3A4, which is responsible for metabolism of 𝗙𝗵𝗃𝗏𝗏. So if you inhibit this, there will be increased levels of 𝗙𝗵𝗃𝗏𝗏 for some time. So it boosts the effect of 𝗙𝗵𝗃𝗏𝗏. So remember this. Side effect of these gravirs is they can cause myopathy and they can cause rashes. So myopathy is more common with raltegravir. Okay. Moving to protease inhibitors are called as NAVIs. Now in the NAVIs, the important thing is that they are going to inhibit the assembly because they will not allow the proteins to break down into smaller components. So they ultimately interfere with the assembly of the viral proteins. Now, all of these drugs, they are metabolized by CYP3A4 except nelfinavir, which is metabolized by CYP2C19. Because of the reason, we'll say that a drug which is one of the most potent in enzyme inhibitor of CYP3A4, which is ritonavir, cannot be given with nelfinavir. This ritonavir is main role is to boost the effect of the other drugs because it is going to inhibit CYP3A4 and it will increase the effects of the other protease inhibitors because they will not be metabolized faster. But it cannot be given with nelfinavir because the enzyme is different here. So apart from nelfinavir, it can boost the effects of the other protease inhibitors. Now, what about other drugs like 𝗪𝗪𝗪𝗏𝗪, darunavir, atazanavir? The booster we use against or for this is 𝗘𝗵𝗔𝗃, just like we did just now, 𝗘𝗵𝗔𝗃. Okay. Now, out of these navirs, the least potent protease inhibitor is saquinavir. Okay. And it has a problem of causing QT prolongation. Okay. Indinavir. What is the drawback with indinavir? It is associated with nephrolithiasis and hyperbilirubinemia. Okay. Now, protease inhibitors have one classical side of or adverse effect we should know, that is dyslipidemia. But the only protease inhibitor which does not show dyslipidemia is atazanavir. Atazanavir. They have no risk of dyslipidemia. Now, how do you treat dyslipidemia because of these protease inhibitors? So, the treatment of dyslipidemia is a drug called as 𝗕𝗵𝗄𝗃. Remember this. So, no risk of dyslipidemia is by atazanavir. And another important thing is which protease inhibitor is associated with intracranial hemorrhage or hepatotoxicity, especially this one which is more important, is tipranavir. Tip, right? Tip is the tip of the head, right? So it can cause intracranial hemorrhage. Tipranavir. Fixed dose combination is available of these protease inhibitors. For example, I told you because one is a booster drug, it is not used as such. It is only used to boost the effect of the other drugs. So we have ritonavir in around 10% plus 𝗲𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 15 and 10% allotonavir, which increases the effect of the lopinavir. Now, let's do another MCQ. Which of the following growth hormone analog that is not used for treatment of growth hormone deficiency, but actually it is used for HIV-associated lipodystrophy? So I just told you that drug is tismorelin. What about the other option? Let's see. What is quinoline? It is just a distractor. It's not a drug at all. Only a distractor. Somatropin. Now, somatropin is recombinant growth hormone, and it is used for growth hormone deficiency. Pegvisomant is a growth hormone receptor antagonist used in acromegaly. Right? So the correct option here is tesmorelin. The second question is, a patient with hemophilia on antiretroviral therapy presents with altered mental status accompanied by nausea, vomiting, and headache. Which of the following medications is most likely responsible for this headache? So remember, there is altered mental state, there's something wrong in the head, nausea, vomiting, headache. So there can be some intracranial hemorrhage or intracranial bleed. So I told you tip of the head, that is 𝗕𝗵𝗏. That is the important thing. Now moving on to the antiretroviral therapy. What are the drugs which are used for antiretroviral therapy? So here we have drugs like the first line drug. Remember the regime is TLD regime. That is tenofovir. We have lamivudine and we have dolutegravir. So these are the first line drugs that we use. Remember, tenofovir is contraindicated in children less than 10 years or where the weight is less than 30 kg because we don't have the safety data here. So replace in such case with abacavir. Okay. Now post-exposure prophylaxis, same drugs you're using. TLD. You have to start within 72 hours of the exposure and continue the treatment for 4 weeks or you can say 28 days. What about pre-exposure prophylaxis? Because you can give it in like where you suspect, like females when there are multiple sexual partners or in the other kind of people. So pre-exposure prophylaxis, what we do is we give tenofovir along with 𝗕𝗵𝗔𝗏. All right. Prevention of vertical transmission. So very, very important that we use 𝗕𝗵𝗏. So here we use 𝗕𝗵𝗏. 𝗕𝗵𝗏. So low risk infant, you can just give this syrup of 𝗕𝗵𝗏 OD for 6 weeks. Right? If there's no other indication given, so you assume you give 𝗕𝗵𝗏 syrup for 6 weeks once daily in a syrup form obviously. But let's say there are high risk case and the female decides against breastfeeding. Then what you do? You give 𝗕𝗵𝗏 plus you add 𝗬𝗫. You give this for 6 weeks. And if the female, the mother, wants to, right? So if the mother wants to do exclusive breastfeeding, then you do the same treatment with 𝗬𝗫, but you extend it to 12. Depending on the condition. So these are the important points which we should know about the non-retroviral and antiretroviral drugs. So today we are going to talk about anti-cancer drugs. So let's get started. Now, in the anti-cancer drugs, we have drugs which are cell cycle specific and the ones which are non-cell cycle specific, right? So first we are going to do the cell cycle non-specific, which are not specific for any cycle. So here we have the alkylating agents. So the alkylating agents, what they do is basically they are going to donate the alkyl group to N7 of guanine. And what happens because of this is that the DNA, they develop the cross linkages between the strands also. So one is interstrands and even the intrastrands. So once these cross linkages develop, it is not easy to break these cross links, right? So that is the problem with this. Now, the drugs in this we have are first cyclophosphamide. Now, cyclophosphamide, what you have to remember is an important adverse effect which is called as hemorrhagic cystitis, and this is due to a metabolite which is acrolein. Which metabolite is responsible for causing the hemorrhagic cystitis? This is acrolein. And what is the treatment for this? So, prophylactically or beforehand only you can give Mesna. So, Mesna is given for prevention, right? And so, this is for prevention, and for treatment, for treating it, you give steroids. Remember. Then, busulfan and procarbazine. Now, busulfan has one important adverse effect which is called as pulmonary fibrosis, and also it can cause bone marrow depression. Now, procarbazine is associated with disulfiram-like reactions. So, these are few adverse effects which you should be knowing about these anti-cancer drugs. These are particular or peculiar to these specific anti-cancer drugs. Then we have the platinum compounds. Now, in the platinum compounds, they just work like the alkylating agents, only it is not the alkyl group, so the platinum group is given. That's why the name is platinum compounds, and they're very, very important group of drugs like cisplatin. So, they all have platin, cisplatin, carboplatin, oxaliplatin. Now, cisplatin is a very, very important drug because it is, you will see it is used in many tumors, just solid organ tumors, and its adverse effect is also equally important, which is asked. So, cisplatin is one of the most emetogenic drug, anti-cancer drug, and the treatment is definitely you give antiemetics. Now, if this is early vomiting, so there is early development of vomiting or early onset of vomiting, then you give drugs like 5-HT3 antagonists, cetrons, antagonists, for example, ondansetron. If it is delayed vomiting, then you give NK1 receptor antagonists like 𝗕𝗵𝗡. Okay, so treat this. Nephrotoxicity, it is one of the most nephrotoxic also. So, for nephrotoxicity, what you do, you give 𝗲𝗎𝑚ifostine. 𝗲𝗎𝗎mifostine. This is going to protect against nephrotoxicity. So, it is protective against the nephrotoxicity. Then L-asparaginase, this is an enzyme. And what is the role of this? It is going to starve the cancer cells of asparagine. Actually, cancer cells, they require asparagine. They can't make their own asparagine, so they take it from the blood cells. Now, L-asparaginase, it is going to metabolize asparagine. Therefore, when it is inhibiting or metabolizing asparagine, it is devoiding the cancer cells of asparagine. So, it dies or starves because of this, right? Metabolizes asparagine. So, remember its adverse effects: hyperglycemia, pancreatitis, clotting defects which can lead to hemorrhage or bleeding, hypersensitive allergic reactions. Yes, it can also cause hyperlipidemia, and is also hepatotoxic. Remember, the one adverse effect it does not have is bone marrow depression. So, it has a, we call it as a bone marrow sparing effect. It doesn't affect the bone marrow, unlike all the other anti-cancer cells. Now, the anti-cancer cells, they have a variety of common adverse effects. One of the most common adverse effects to all of these anti-cancer drugs is bone marrow depression, except for L-asparaginase, vincristine, and bleomycin. So, these three drugs, they have a bone marrow sparing effect. They do not affect the bone marrow. Alright. Next is the cell cycle specific drugs. Now, in this we have first the S phase. So, here we have cell cycle specific. So, here we have drugs in the S phase. Very, very important again drug group is anti-metabolites. So, the metabolism is going to suffer here. which we have methotrexate. Now, methotrexate inhibits the dihydrofolate reductase, inhibits the formation of tetrahydrofolic acid, and also inhibits the thymidylate synthase. So, this is the important mechanism of reaction, mechanism of action of methotrexate. Now, it can also cause bone marrow suppression. It is hepatotoxic and it causes megaloblastic anemia as well. So, what can we do because of this? Now, methotrexate, we know these are the adverse effects. So, you can give here, we give folinic acid rescue. So, folic acid is not given because it needs to be activated, and this drug is already blocking the step of dihydrofolate reductase. So, we have to give folinic acid, prepared active folinic acid, not the folic acid. So, you can give folinic acid, and this is called as folinic acid rescue. The other name for this is citrovorum factor leucovorin. We can give this. Now, in case there is an extreme case of toxicity, so for extreme toxicity, you can give 𝗤𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 going to cleave methotrexate. Then pemetrexate, same lines. Then we have 6-mercaptopurines. Now, what is 6-mercaptopurine? So, name tells you it is you can say a fake purine is going to incorporate and a fake nucleotide is going to form. So, this is going to inhibit or affect the purine metabolism, right? 6-mercaptopurine, it is going to affect the purine metabolism. Now, this 6-mercaptopurine, it is metabolized by xanthine oxidase. Now, if 6-mercaptopurine you are giving and it is getting metabolized by xanthine oxidase, if you give allopurinol alongside, now why will you give allopurinol? Because what happens when you give anti-cancer drugs, there is lysis of the cells, right? So the cells release a lot of purine and there can be increase in the uric acid levels. It is called as a tumor lysis syndrome. So for that you need to give drug which is going to decrease the the uric acid. So xanthine oxidase inhibitor, allopurinol can be given. You can give it with raspuricase. So if a patient is already on a drug which is 6-mercaptopurine and you are giving allopurinol along with it, allopurinol is what is going to do, it is going to inhibit this enzyme xanthine oxidase. Yeah, so for uric acid level it is good, but what happens here in this drug is that 6-mercaptopurine cannot be metabolized. So there was going to be increase in the levels of this particular drug. So enhanced toxicity because of 6-mercaptopurine. So therefore you need to decrease the dose of, so therefore decrease the dose of 6-mercaptopurine here. Then 5-fluorouracil, this is it is going to affect the pyrimidine metabolism. Affects the pyrimidine metabolism, right? And it can cause side effects like esophagitis and hand and foot syndrome. This is what you see in the hand and the foot syndrome. So what you can do here is treatment. It is you can give vitamin B12 for prevention. Then we have capecitabine, which is a prodrug. It is a prodrug of 5-fluorouracil. Then we have gemcitabine and hydroxyurea. Hydroxyurea, what you need to know about this particular drug is that this is a radiosensitizer. It is a radiosensitizer. So if somebody like patients of head and neck cancer, they have been given radio, they have been treated by radiotherapy beforehand. So when you give this drug to such patients, the area where the radiotherapy was given previously, there can be rashes which can develop, right? So that is called as radiosensitizer. It's a radiosensitizer and it is the drug of choice for sickle cell anemia. Okay, so it's a drug of choice for sickle cell anemia. Moving on to the next question here before we go on is, which of the following is the most effective drug for managing the doxorubicin induced cardiotoxicity? Now, this is a very, very important question, and we will come to the answer right after 1 or 2 slides, and let's study this first and then I come back to the answer. So here first we are going to do M phase drugs, which are vinca alkaloids like vincristine, vinblastine and vinorelbin. We have taxanes and we have 𝗥𝗓𝗡𝗏𝗡. So all three, we will understand the mechanisms together. So we know that in the mitotic phase or the M phase, there is spindle formation. So here, what is going to happen? So there is formation of these spindles. Now when these spindles are being formed, these spindles are composed of beta and alpha subunits. So these microtubules which form the spindle, microtubules, they form the spindle. So they are comprising of beta and alpha subunits. So they come together. So we have the polymerization. So this is, let's say this is a beta and this is alpha, then beta, then alpha, so on and so forth. The polymerization has to take place, and that's what you see in the spindle formation. Right? If this is not polymerized, the spindle formation will not occur. And then after the spindles are formed, so these are the chromosomes here, and then they need to be split also, depolymerized, so that the daughter cells are formed. So this is very important phase of mitosis. Now, what happens with these drugs? Now, when you give vinca alkaloids, what are they going to do? They are going to bind to beta subunit, right? And they are going to inhibit the polymerization. So spindle is not going to be formed. They are going to stop the mitotic process right in the beginning only. So this is what the vinca alkaloids do. Then taxanes, paclitaxel, docetaxel, what they're going to do? They are going to inhibit the depolymerization. So once this process, these polymers are formed, they need to depolymerize also so that we can split these daughter cells. Now that is inhibited. The step is now frozen. So therefore, there is not going to be any division. Cell division will not take place. So that is one thing. 𝗥𝗓𝗡𝗏𝗡, it is going to stabilize the, they are going to stabilize the microtubules. So that also means the same. Just like taxanes, they are not allowing the microtubules to move, polymerize, right? So these are the various points on which these drugs are going to act. All right. Moving on to the important points about these drugs, vincristine, vinblastine, vinorelbin. What are the important adverse effects? It can cause bone marrow depression, syndrome of inappropriate ADH secretion, and nerve palsy. Remember, now when you're talking about the bone marrow depression, this is seen with them, but exception to the rule is, we just now did, which of them has a bone marrow sparing effect? Yes, this is vincristine, except for vincristine. So how do you treat these bone marrow depressions is, you give various hematopoietic factors, like if there is anemia, you give erythropoietin. If there is neutropenia, you will give the colony stimulating factors, right? If there is thrombocytopenia, you will give another those growth factors. So accordingly, you are going to give this hematopoietic growth factors. Hematopoietic growth factors. Then for nerve palsies, you can give vitamin B12, and for syndrome of inappropriate ADH, we can give hypertonic saline. All right. Now taxanes, they cause stalk and glove neuropathy. Again, vitamin B12 can be given. Now 𝗥𝗓𝗡𝗏𝗡 is usually given in case of taxane resistant tumors. So if taxane is not able enough, it's not able to inhibit the depolymerization enough, then you give 𝗥𝗓𝗡𝗏𝗡. So for taxane resistant tumors. All right. Then we have the G2 phase drugs, irinotecan and topotecan. So Topotecan, irinotecan, what are they? These are the topoisomerase 1 inhibitors. So this is topoisomerase 1 inhibitor. While etoposide and all this is a topoisomerase 2 inhibitor. First is irinotecan. It can cause diarrhea. That's a very disturbing side effect. Now this diarrhea, if it occurs early, then that means this is because of the cholinergic side effect. So early means there is cholinergic side effect. So here the treatment would be atropine, anticholinergic. But if it is late or delayed, so that is because of the problem or the disruption of the gut wall. So in late, so there is disrupted gut wall. Then the treatment is loperamide. Then coming to this important side effect with this group of drugs, because that was asked in the question, doxorubicin, daunorubicin, epirubicin. Now all these drugs you will see have ruby in their name. Ruby. So rubies are red in color, right? Rubies are red in color, right? Red in color. So red color is the color of the heart. So these drugs are highly cardiotoxic. And why are they cardiotoxic? This is because of the iron free radical, iron mediated free radical damage. So what is the best possible treatment here? To give a drug which can chelate the iron. So the treatment is dexrazoxane, which is an iron chelator. So dexrazoxane is an iron chelator, and that will avoid or prevent the free radical damage on the heart, because this therefore leads to CHF due to cardiomyopathy. Okay, so if we go back to this MCQ here, which of the following is the most effective drug for managing the doxorubicin including cardiotoxicity, the answer should be dexrazoxane, right? Because the other drugs, if you see, what are this? Dexamethasone is a steroid. Aprepitant is a NK1 receptor antagonist, which is used for MSA. So it is anti-emetic. Amifostine, it is used for, you just now did, for cisplatin induced nephrotoxicity. Okay, so the correct answer is dexrazoxane. Now coming to the bleomycin, the drug which is left is bleomycin. Now bleomycin, what is important to know, that the major adverse effects which they ask you are flagellate dermatitis. So they can show this picture to you as an image based question, and you will see that there is dermatitis. It's like a flagella, small lines are there. And it can also lead to pulmonary fibrosis. These two are the main adverse effects of bleomycin. Why it happens is because in skin and in the lungs, there is deficiency of the inactivating enzyme called as bleomycin hydrolase, right? Now bleomycin hydrolase, what is the role? It causes the inactivation of bleomycin. Now in skin and in lungs, it cannot inactivate. Therefore, there is increase in the levels of bleomycin in these areas. Drug accumulates here, so that is why these side effects occur with this particular drug. Now this is a way to memorize the specific side effects of the anti-cancer drugs which are important, right? So first, if you start from the head, we have doxorubicin can also lead to alopecia. So doxorubicin causing alopecia. Doxorubicin also we did, it is cardiotoxicity. So on the heart, you make this D, so it is like doxorubicin. Then ears are basically for ototoxicity, which is seen because of cisplatin. See, cisplatin C in the form of ears. T in the eye, it can cause changes in the vision. Plicamycin P in the place of nose can cause nosebleeds. B stands for two drugs. One drug here it is bleomycin and the other one we can also write busulfan. So B in the place of lungs. So B stands for two. B is second letter, A is one, B is two. So two lungs. So two drugs, bleomycin, busulfan, causing pulmonary fibrosis. Then M is methotrexate. It is hepatotoxic. Also, it can cause bone marrow suppression. Then peripheral neuropathy. So you see the limbs, and in the limbs it is in the form of V. So this is peripheral neuropathy with vincristine, right? Then cisplatin, again in the place of kidneys, there are two C's. This stands for nephrotoxicity, is one of the most nephrotoxic drugs. Then cyclophosphamide in the bladder causing hemorrhagic cystitis. And in the bone marrow, as I already, one is methotrexate, the other is fluorouracil, that can lead to bone marrow or myelosuppression. So this is a way to remember the specific adverse effects of these anti-cancer drugs. All right, now let's move on to important treatment regimes of different cancers. So as I told you, as a rule, in most of the tumors, you will see the solid tumors, the drug is usually cisplatin. So it's a very safe bet. It's a very often asked question that there are bladder tumor, esophageal, lung cancer. Cisplatin looks like a very safe answer. But let's see. So for the head and neck cancer, yes, we have the first is cisplatin. An alternate therapy is cetuximab. Cetuximab is tux. You know where you wear a tuxedo, and whenever you wear a tuxedo, you wear that small black tie. Where is the tie tied? It is tied in the neck. So head and neck cancer, cetuximab, you can remember. Lung cancer, again you write cisplatin. There are other drugs also, but from here it is cisplatin. Esophageal cancer, again you can give cisplatin and you can add 5-fluorouracil. Cervical, bladder, ovarian cancer. So for cervical cancer, only cisplatin is sufficient. For bladder cancer, you keep cisplatin and you add 𝗕𝗵𝗂𝗏. Then for ovarian cancer or uterine cancer, what you do is you will keep cisplatin and you will give paclitaxel, right? Retinoblastoma, we give carboplatin. Testicular cancer, right? So the regime is BEP, right? P is a platinum compound. Again, cisplatin. Okay. Then E is etoposide and B is bleomycin. So this is your BEP regime. For colon cancer, we have two regimes. We have FOLFOX regime and FOLFIRI regime. So FOLF is common to both. So this FOLF is common to both. So FOL stands for folinic acid, that is FOL, and F stands for 5-fluorouracil. Now OX stands for oxaliplatin while this IRI stands for irinotecan. Okay. Then we have anal or rectal cancer. So here we give 5-fluorouracil plus mitomycin C. Choriocarcinoma, the drug of choice is methotrexate. Moving on to the bone marrow, important bone marrow cancers, we have the regimes here. We have for ALL, we have the 𝗣𝗚𝗏 regime, and in the 𝗣𝗚𝗏 regime, we have vincristine, prednisolone, 𝗙𝗛𝗏𝗔𝗟ase, and donorubicin. That's the 𝗣𝗚𝗏 regime. CLL, if FCR regime. So we have fludarabine, cyclophosphamide, and rituximab. CML, very important. We have the drugs. Here you remember we have drugs which are going to, these are the tyrosine kinase inhibitors of BCR and ABL, which is the abnormal fusion proteins. Abnormal fusion proteins, right? So we have, if we see here, one is the, this is the ABL, and we have the BCR. So they are fused abnormally. They should be separate, but they are fused together. So abnormal fusion proteins, tyrosine kinase inhibitors of this. So we have first generation, second generation, and third generation. So the first generation, we start from the CML, the first generation drugs. And here we have the first generation, means 1 or I, we can write imatinib. Imatinib. There is no improvement or resistance. Then you go to the second generation, that is dasatinib. Or we have Nilo, right? Then resistance, then we go to the third generation, which is ponatinib. Imatinib, dasatinib, but drug of choice would be imatinib only here. Moving to the Hodgkin's disease. Again, the regime is ABVD. Again, this is an important regime. ABVD for Hodgkin's disease. So we have adriamycin, right? We have bleomycin. We have vinblastine, and we have 𝗙𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 𝗙𝗏𝗏𝗏𝗏. If there is relapse, then we give a immune checkpoint inhibitor, which is your nivolumab, right? So these days the immune checkpoint inhibitors are quite often asked, and they're very promising drugs. So therefore, you must know these drugs. Moving to the non-Hodgkin lymphoma. So the non-Hodgkin lymphoma is R-CHOP or CHOP-R regime. So R stands for rituximab and C stands for cyclophosphamide, right? H stands for hydroxydonorubicin. O stands for oncovin, which is the other name for vincristine, and P stands for prednisolone. So this is the R-CHOP regime. For multiple myeloma, we have bortezomib, dexamethasone, and lenalidomide. Polycythemia vera, again the drug is hydroxyurea. There is one more which is called as hairy cell leukemia. Hairy cell leukemia, and we have the drug 𝗙𝗏𝗏, which is the drug of choice. Alright, now very important question again, very often asked this cancer. Which drug is used for the treatment of trastuzumab resistant HER2 positive breast cancer? So the answer here is, let's see the options first: vismodegib, lapatinib, vemurafenib, and erlotinib. So here the correct answer for us is lapatinib, because the first one, which is vismodegib, is used for advanced basal cell carcinoma. Then we have vemurafenib, it is used for metastatic thyroid cancers and melanoma. And erlotinib is used for lung cancer. Alright, so let's go and understand what are the important drugs for management of breast cancer. Very important topic. So first we are going to divide it into two types. One breast cancer which is ER positive, estrogen receptor positive. The other one is HER2 positive. Treatment would differ accordingly. So in the ER positive cases, if the patient is premenopausal, before menopause, then the drug of choice for us is tamoxifen. Tamoxifen is a selective estrogen receptor modulator because it acts as an antagonist on the breast tissue. So here you want an antagonist on the estrogen receptor. Postmenopausal, you know that the main source of estrogen in the postmenopausal females, it is a peripheral conversion of or the formation of the estrogen, and the enzyme aromatase is important here because it converts the periphery, the testosterone, into the estrogen. So you want to block that because ovary is not the main source here. So you have to stop that peripheral conversion. So in the postmenopausal cases, the drug of choice would change to letrozole, which is a aromatase inhibitor. Now in HER2 positive, please remember the drug of choice is trastuzumab. That was just put in the question. But if there is resistance to trastuzumab, then we give the drug which is lapatinib in resistant cases. Lapatinib, niratinib, they are active against both HER1 and 2. Tucatinib is only for, tu means 2, tucatinib is only for HER2. Alright. Now other important anti-cancer drugs. So we have for the lung cancer, we have the mnemonic is CAGE, C-A-G-E, CAGE, which is ceritinib, afatinib. Now G and E, very important, it is gefitinib and erlotinib. Gift to the lungs, gefitinib, erlotinib, right? Renal cell cancer, CAPS. We have cabozantinib, we have axitinib, we have pazopanib, and with the two S's, we have sunitinib, and we have sorafenib. This is the drug of choice. Now, sorafenib is also used for the liver cancers as well as the renal cell cancer. So, you can remember there is a sore, right? There is a sore on the kidneys. There is sore on the liver. So, sorafenib is used for kidney cancer as well as the liver cancer. And Sunita has a sore on the kidney only. Sunita has a sore on the kidney. So, sunitinib, sorafenib, used for the kidney cancers, but SOR is also there on the liver, so sorafenib is also used for the liver cancer. Then we have the GIST. GIST is gastrointestinal tumors, and here the mnemonic is RISU. R stands for regorafenib. I is a very important drug, which is the drug of choice, which is imatinib. Right? This is the drug of choice. And then Sunita also has gastric problems. Sunita has a lot of problems. Sunita has a sore in the kidney. She has a gastric issue as well. So, in the renal cell cancers and in the GIST. But drug of choice in the GIST, as well as here we have done in this case of CML. So, the drug of choice remains imatinib in these two cases, CML and in the GIST. Then CML, it has now bind is the mnemonic. So, we have bosutinib. So, again I will repeat here, the drug of choice is imatinib. Drug of choice. If there is resistance, then we go to dasatinib. Right? N stands for nilotinib. Right? So, imatinib is a drug of choice. That is the most important thing here. And secondly, imatinib is drug of choice for GIST. So, remember, imatinib drug of choice in two cases. One is CML and other is the GIST. And Sunita has two problems, kidney issue and on the stomach. So, sunitinib is used in GIST as well as the kidney. There is a sore on the liver and the kidney. So, remember, sorafenib is used in liver cancer as well as the renal cancers. So, this way you can associate and learn to make it little better. Then for the medullary cancer of thyroid, we have a drug called as vandetanib. Now remember, there is a van parked on the neck. Imagine a van is parked on the neck. There is a thyroid in the neck. So vandetanib is used against medullary carcinoma of thyroid. Hepatocellular carcinoma, I just told you, there is a sore on the liver. So again we have sorafenib. That is very important. Colorectal cancers. Now the drug is regorafenib. Now color. Just remember the color. 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 Color is white. White in Hindi is gora. So the color is white or gora. So the drug is regorafenib. Mast cell tumors. You need mast. So that is macetinib. This is easier to associate. Mast cell tumors, macetinib. Then very, very important topic, which is a lot of times now asked in the exams, is immune checkpoint inhibitors. These are the monoclonal antibodies which work as immune checkpoint inhibitors. Now first, which are these inhibitors? So the mnemonic is new star drugs acting at immune checkpoint receptors. So we have nivolumab and we have star say dostarlimab, then we have durvalumab, we have avelumab, atezolizumab, ipilimumab, then we have cemiplimab, then we have pembrolizumab, and then we have retifanlimab. So all these are the immune checkpoint inhibitors. Now we should understand the mechanism as well, and then I'll tell you the different targets as immune checkpoint inhibitors. Now let's say there we have, this is for us a tumor cell, right? This is a tumor cell, and here we have the T cell. Now T cell, they have a receptor here which is called as PD1, programmed death receptor 1. Now the tumor cells, it has a ligand. It forms a ligand for this receptor which is called as programmed death ligand 1. Had this ligand not be there, then the T cell would have recognized this tumor cell to be enemy and it would have killed it. But what this enemy does is it wants to be just friends with this particular T cell. So what it does is it tries to do friendship with this drug. It says that I am just like you, buddy. I bring you a gift and we are similar in kind. So PDL1, it is going to bind to this PD1 receptor and it deceives this T cell. So this T cell is going to become inactive. It will say, okay, this is my friend. I will not destroy you. Very clever of the tumor cells. Now, what we have done is we are becoming more clever than the tumor cells. We try to break the bond. We try to try not that they should not be friends with each other. So what we do is, we are going to make drugs which are either going to block this PDL1 or they are either going to block this PD1. So they won't be able to meet each other only, and the tumor cell will not be able to attach the PDL1 to PD. So now the T cell knows that because the tumor cell hasn't shaken hands with me, that means it is not my friend, it's my enemy. So now the T cell will no longer be inactive, it will be active and it will destroy the tumor cell. So we have PDL1 inhibitors and we have PD1 inhibitors. That is one concept, okay? That is concept number one. So we have certain drugs. Now we have another concept in the immune checkpoint inhibitors, which is CTLA4 inhibitors. So what is that fundamentally? Let's see. Then we have the antigen presenting cell, APC, in the body. And when it comes, it has MHC on it and it has B7 on it. To stimulate T cell, it needs to activate or it needs to attach both MHC and B7 to the T cells, to the various receptors. So again, I'll make a T cell here. So this is a T cell. Now here we have T cell receptor. Here we have CD28 and we also have CTLA4. Now when the antigen presenting cell, it comes to the near the T cell, it will first, it has to show two proofs to it for it to be accepted by the T cell. So what it does is, MCH, it forms a bond or it combines with the TCR, that is step number one, if it has to stimulate the T cell. Number two, there has to be the second point of stimulation, which is called as co-stimulation. So co-stimulation occurs if B7 binds to CD28. So co-stimulation is when B7, it binds to CD28. First stimulation occurred here when MHC binds to the T cell receptor. Now, if B7, so when this B7 binds to CD28, there is T cell activation. Okay, remember this point, T cell is active. But when B7 binds to CTCA4, then there is T cell inactivation, which means T cell is going to rest. It has been inactive. It is not going to go and target the cancer cells. So what should be our aim? That we want that this stimulation should be there and this stimulation should be inhibited. So if we give drugs which are going to block CTLA4, then automatically there is no other site left, no. So only CD28 is going to bind to B7 and there is going to be T cell activation, and this co-stimulation will lead to the further process, that is T cell activation, and therefore it will target the various cancer cells. So the immune checkpoint inhibitors, they are going to either number one, inhibit PDL1, or they are going to inhibit the receptor, that is the PD1, or they are going to inhibit the CTLA4. That is the crux or the overview of how it happens. Now let's see which drugs are going to do what. So remember, drugs acting at I, all these four together. So drugs acting at, they are going to inhibit the PDL1, while I, it is going to inhibit the CTLA4. Rest all of them, rest, you can say rest all, they are going to inhibit the PD receptor, PD1. Okay, so drugs acting at, they are going to inhibit the PDLA1. Immune ipilimumab, it is going to inhibit the CTLA4, and rest all of them are going to target the PD1. Okay, so out of these, the most important asked questions is on nivolumab and the pembrolizumab. So this you should know in more details as compared to the others. So moving on to the nivolumab, we'll do the uses after this. Dostarlimumab, remember it is star is present in the endometrium. So this is used for endometrial cancer along with pembrolizumab. This is also very important for treating endometrial cancer. Durvalumab and atezolizumab, they are both targeting the bladder cancer. Bladder cancer. Durva and atezoli both targeting the bladder cancer. Avelumab, it is for the Merkel cell cancer. Merkel cell cancer. Even retifanlimab is also for the Merkel cell cancer. Ipilimumab, because this is going to work against malignant melanoma. And semiplimab is going to target squamous cell carcinoma of the head and neck. Right? Semiplimab is going to target the head and neck, right? That is important. So these are the important uses of the immune checkpoint inhibitors. Now, details you should know about this nivolumab and pembrolizumab. So, nivolumab is a PD-1 blocker, and let's study the uses of these drugs. Metastatic melanoma, non-small cell carcinoma, Hodgkin. So these are the three important uses that you must know. Then we have renal cell cancer, squamous cell cancer of the head and neck, urothelial, colorectal, and the liver cancer of the hepatocellular cancer. Pembrolizumab, again remember the uses by the mnemonic pembroli. So primary use is in number 1, endometrial cancer, melanoma, then breast cancer, especially which is triple negative, renal cell cancer, esophageal cancer, lung cancer, non-small cell lung cancer. Then we have the monoclonal antibodies. The important, there are so many, it's not possible to know all, but the very important ones here that we should know from this particular topic is first is against the CD20, which is rituximab. Remember, Ritu did not get no call. So she did not get any call, no call. No call means it is working against, no means non-Hodgkin lymphoma, call CLL. So she did not get a call, and therefore alum called her. So this is also against, this is against the resistant CLL. Ritu got no call, so therefore alum called her. So resistant CLL, if Ritu doesn't get a call, then alum calls. Teplizumab, right? Tepli means it is against type 1 diabetes mellitus. Type and tep. So tepli against type 1 diabetes mellitus. Basiliximab, daclizumab, which is targeting CD25. So B and D. So it blocks and it attacks the division also. Blocks the division. So blocks interleukins 2 and inhibits the division of the T cell. So where it is used? In acute transplant rejection. You don't want active T cells here. Acute transplant rejection. So they blocks interleukin 2, inhibits the division of T cells, therefore used in acute transplant rejection. EGFR, cetuximab, panitumumab. I told you tuxedo when you tie, remember a black tie, necktie that we have. So it is used against head and neck cancer. So tuxedo also comes with a pant. So we use panitumumab, right? Then HER2 we already done for the breast cancer. Breast cancer, trastuzumab and pertuzumab. Then 𝗤𝗚𝗏. Remember Lara Croft from the Tomb Raider movie? So Lara Croft, Tomb Raider, she got soft tissue injury. So this is used for soft tissue sarcoma. Remember that. So Lara in the Tomb Raider, she got hurt many times. So she got soft tissue injury, soft tissue sarcoma. 𝗍𝗲𝗍𝗐𝗍𝗏. Now this is the target is VEGF. Now what is the role of VEGF? It inhibits the vascularity because tumor cells, they require blood supply, right? So it is providing the vascularity, right? So VEGF, it is going to provide vascularity. Now 𝗍𝗲𝗍𝗐𝗍𝗏, it is going to evacuate the blood from these tumors. So which are these tumors which are highly dependent on vascularity, which are highly vascular tumors? So these tumors are the kidney tumors. So it is helpful in renal cell tumors. It is helpful in breast tumors and in the colorectal tumors. So these are highly vascular tumors. So it is going to evacuate the blood supply from there. So it is 𝗍𝗲𝗍𝗐𝗍𝗏. So this is how you can associate and remember these. Otherwise, it becomes a little tricky to remember the monoclonal antibodies. So remember, do not waste a lot of time on this monoclonal antibodies. The few ones you should know. The rest you can leave and you can concentrate on the more important topics which are actually lying there. So with this, we finish the anti-cancer drugs and the few of these important monoclonal antibodies. So let's do today the drugs for peptic ulcer. So we are going to first classify the drugs which are required or which are used for the treatment of peptic ulcer. So we have first the drugs which are going to neutralize the acid secretion, then the drugs which are inhibiting or decreasing the gastric acid secretion, then the drugs which are going to protect the gastric mucosa, and then drugs used for management of H. pylori infection. So let's do them one by one. So we know that in the stomach, the gastric parietal cells are there and they lead to the formation of the gastric acid. So this is the hydrogen potassium ATPase pump, or also we call as the proton pump, and this releases H ions. It combines with the chloride acid. This is the hydrochloric acid form. So the drugs are going to neutralize this HCl. They are called as antacids, right? So we have here antacids. So we have magnesium hydroxide, aluminium hydroxide, calcium carbonate. Remember, these have certain side effects also as well. For example, magnesium hydroxide causes diarrhea. Remember, calcium causes contraction. Magnesium works opposite to calcium. So if it is causing relaxation of the muscles of the intestine, it will definitely lead to diarrhea. And opposite to magnesium effect is of aluminium, and this leads to constipation. Calcium carbonate, if you take excess of it, it can lead to formation of the kidney stones. Right? So this is made use of in which conditions? So neutralizing or antacids, they are used in peptic ulcer and gastroesophageal reflux disease. Then we have drugs which inhibit or decrease the gastric acid secretion here. So these are the most important drugs. So we have this proton pump inhibitors here, PPIs. We have potassium channel blockers. We have H2 blockers. And we have anticholinergic drugs. Anticholinergic drugs. So here we have pyrenzapine. Pyrenzapine. It is an M1 blocker, but because now better drugs are available, we don't really use them. So this PPI and PCAB, both of them, they are going to target hydrogen potassium ATPase. One targets the proton part and the other targets the potassium part. So they are going to work here. Then the drugs which protect the gastric mucosa, or they are called as the mucosal protective drugs here. So we have sucralfate and we have the colloidal bismuth subcitrate. Now for treatment of H. pylori infection, we require all these drugs, but alongside we will also require antibiotics. You have to add antibiotics to take care of the H. pylori bacteria. Now moving on to the important drugs like H2 blockers here for us. So H2 blockers, we have cimetidine, ranitidine and famotidine. So famotidine is very potent drug and it is one of the longest acting out of them, longest acting. Now cimetidine is associated with a lot of side effects because it can cross the blood-brain barrier. So this can lead to hallucinations, it can lead to convulsions. In males, it can have anti-androgenic effect, anti-androgen effect, which can cause impotence, and it can cause gynecomastia increases because it increases the prolactin levels. So we don't use cimetidine currently. That's one of the reasons. All right. Now, these drugs are going to block the H2 receptor. So they are mostly effective in taking care of the nocturnal acid secretion. So if someone complains of nocturnal gastric acid secretion, so they are more they are more efficient in that respect. So these drugs, H2 receptor blocker agents, they are used prophylactically to manage post-op aspiration pneumonia, right? So they are given preoperatively and they can manage the post-op aspiration pneumonia. Now there is a second or the latest generation of H2 blockers, second generation. We call it as, the drug is lafutidine. So it's a second generation drug. Now this has some additional actions like it increases the nitric oxide production and it also increases the mucosal blood flow because of that, mucosal blood flow, right? And mucus production. So that's why this has additional effects and therefore can be used in peptic ulcer, it can be used in gastroesophageal reflux disease and dyspepsias, etc. Now this drug is only marketed and it is marketed in India, Japan and South Korea. Okay, so this is the second generation of this drug. Then very important and common drug group which we have are the proton pump inhibitors. So proton pump inhibitors, so these are going to target, we know, hydrogen potassium ATPase and these are irreversible in nature, right? These are irreversible in nature. Also they are called as hit and run drugs. One of the hit and run drugs, irreversible nature. So they are usually given as an enteric coated tablet and taken on an empty stomach before breakfast because food will, or you can say that they need to be ready before the food comes, before you take the food and the acid is secreted, because once the acid is secreted, then it cannot have any effect. So number one, we have to basically, because it targets basically the food induced acid secretion. So if you give it along with the food, then it will not be able to take care of the acid production, because see what happens is that, so when you give this drug, it doesn't have a local action. It will first enter the bloodstream, and then through the bloodstream, it is going to go and act on this hydrogen potassium ATPase. Remember, these are prodrugs and they need activation in this parietal cell, and they get activated at acidic pH. Acidic pH. So they need acidic pH for activation, and then that active compound is going to block the hydrogen potassium ATPase. But all this process will require some time, around 1 hour. So if you give it along with food, what will happen? The acid will immediately be secreted because of the food, but this will not be able to have any effect. So it has given actually 1 hour before food. That is important, right? All right. So which of them is a fastest acting proton pump inhibitor? And we have the racer, which is rabeprazole. Rabeprazole. Racer is just to make you remember, R for race and R for rabeprazole. They are the fastest acting, rabeprazole. Drug of choice for almost all these conditions like peptic ulcer, gastroesophageal reflux disease, Zollinger-Ellison syndrome, then Barrett's esophagus. So in all these conditions, these drugs are the drug of choice. Safest in pregnancy is lansoprazole. Lansoprazole. Which of the following has minimum drug interactions? Again, we have rabeprazole. Rabeprazole. Most potent proton pump inhibitors that we have are 𝗖𝗵𝗋𝗔𝗟 and dexrabiprozole. These are most potent now. Least potent is pantoprazole. Side effects. Now they have a side effects also, because what happens is, if you use them for a longer period of time, they will lead to decrease in the absorption of calcium and vitamin B12. So because of deficiency of calcium, patient will have osteoporosis. Osteoporosis. Deficiency of vitamin B12, that can lead to megaloblastic anemia. Then they can also cause hyperprolactinemia. Now, of late, warnings have been issued that if you use them for a longer period of time, they can cause chronic kidney disease. So they are damaging to the kidneys as well. Then yes, intestinal infections are more common, because what they do, they increase the gastric pH. So therefore, there's more chances of the intestinal infections. The patient will have diarrhea and other issues of the GIT. Then gynecomastia, especially with omeprazole, it is rare, but yes, it can occur with the omeprazole. Now, very, very important is one of the drug interaction of omeprazole with a drug which is clopidogrel. Now, clopidogrel is an antiplatelet drug, right? And it is a prodrug which needs to become active. So, clopidogrel, to convert into this active form, requires the enzyme 𝗖𝗵𝗔𝗚9. Now, proton pump inhibitors, especially omeprazole, it is an inhibitor of this enzyme. So, a patient on clopidogrel, if patient takes omeprazole, omeprazole is going to inhibit this enzyme and the activation of clopidogrel will not take place. Therefore, the patient will have failure of therapy with clopidogrel, right? So, it predisposes that person to develop stroke or myocardial infarction. So, here if you see, the safest drug out of the lot is that you can give rabeprazole. But omeprazole is absolutely contraindicated along with clopidogrel. So this is very, very important drug interaction. All right. Now, we have these new groups, which is the potassium competitive acid blocker, or we call it as PCAB. So initially we only had proton pump blockers, right, which targeted the proton part. So these drugs are going to target the potassium part of the hydrogen potassium ATPase. So how are they different? And these are called as prazins. So we have vonoprazan, rivaprazan. So how are they different is, number one, these are reversible blockers. Unlike the proton pump inhibitors which are irreversible, these are reversible blockers. They block both basal and food induced acid secretion. Proton pump inhibitors only blocked the food induced acid secretion. They will take care of the basal as well as the food induced acid secretion. They need not be given on an empty stomach, right? They have no interaction with food, just like unlike rather the PPI, so they need not be given on an empty stomach. So these are the differences between potassium competitive acid blockers and the proton pump inhibitors. So currently they use is only in case of H. pylori infection. That is on the primary use currently. Then we have the prostaglandin E1 analog, which is called as misoprostol. So remember, this is a specific drug for NSA induced ulcer, because prostaglandins normally they are protective because they help in synthesis of the mucus. So they protect the mucus layer, right? So they are going to form a protective covering, right? So they will protect the lining of the stomach. But when you give NSAIDs, they are going to inhibit the prostaglandin synthesis. So this mucus cover will be damaged or not formed. So if we see, they are going to help in the prostaglandin action. Misoprostol so seems like the very specific drug for NSAID induced ulcer. But overall, if we see, the drug of choice for NSAID induced ulcer is still PPIs. They are more specific, but the drug of choice is still the PPIs. The side effects of this misoprostol is that it can lead to diarrhea. So diarrhea is a side effect. Okay. Now coming to ulcer protectives. Now ulcer protectives like colloidal bismuth subcitrate, 𝗏𝗏. Now they also help in protecting the gastric mucosa. So what they do when you give these drugs, so you're giving these drugs, they form a polymer. They come together, form a polymer. And let's say here we have the ulcer. So they are going to form they're going to cover this by forming a polymer. So they cover this. So when there is acid release, acid will not come in touch with the ulcer, and therefore the patient will not feel any pain. So that's why they call as ulcer protectives. But remember, they need a pH. Again, they need an acidic pH. So pH less than 4 is required for polymerization of these compounds. Otherwise, they will not be effective, right? So this is very important to know. So these are used in, like sucralfate is used in peptic ulcer. Colloidal bismuth subcitrate, this is used in quadruple therapy in H. pylori. So in H. pylori infection. Okay. Now this is a classical image based question we can ask you. So what is this adverse effect due to? This is a black tongue, and this is seen with colloidal bismuth subcitrate. This is the adverse effect. So this colloidal bismuth substrate can lead to black tongue or it can lead to black tarry stools as well. So black stools, black tongue, all because of colloidal bismuth substrate. Then drugs for H. pylori. So what is the regime for anti-H. pylori drugs? So we have the triple drug regime, which is called as the CAL. You can remember CAL, CAL. In the triple drug regime, we have clarithromycin, 500 milligrams. Then we have amoxicillin, 1000 milligram, and lansoprazole, that the PPI, 30 milligrams. So all these drugs you use twice daily for 14 days. So most of the patients, they recover. But let's say the patient does not show any sign of recovery, then you shift to quadruple therapy. Quadruple means 4. So this was triple, this is triple, and then you shift to the quadruple therapy. That is 4 drugs here. So you L, B, M, T. So again, this is lansoprazole, lansoprazole. This is the bismuth, colloidal bismuth substrate. This is an antibiotic, metronidazole. And we have another antibiotic, tetracycline. So these drugs, again, they are given for a period of 14 days. So if triple doesn't work, then we shift to the quadruple therapy. So sometimes they ask you which antibiotics are used for management of the H. pylori infection. These are the antibiotics, metronidazole, tetracycline, amoxicillin, they can be used. So in the anti-H. pylori triple therapy, let's say the patient shows hypersensitivity reactions or allergic reactions to amoxicillin, then we can replace that with metronidazole as well. So this was about the drugs used in peptic ulcer.